ஆடியோ கொடுத்து அது அப்பா கொடுத்தது அது அங்கேயே போட்டோம் ரெடி இருக்கு.
ஓகேங்க சார்.
சார் பார்த்துட்டாரு சார் அந்த பீடிஎஃப் இருக்கு சார். சார் பார்த்துட்டாரு. இப்போதைக்கு ஆப்டிமைஸ் பண்ணுங்க, நான் உங்ககிட்ட பேசுகிறேன்.
நானும் பேசுகிறேன்.
போட்டு ஸ்க்ரீன் ஷேர் பண்ணிக்கிறேன். ஸ்லைடு மட்டும் சார் பேசும்போது ஸ்லைடு மட்டும் அதில் ஸ்க்ரீன் ஷேர்
அதுலேயே காட்டிங்க. அவ்வளோதான். அப்படியே கமெண்டோட இந்த ப்ரோக்ராம் நைஸ் ப்ரோக்ராம் சூப்பர்னு பார்த்தோங்க. இதுக்கு ஃபெஸ்டிவலாவுக்கும் அதுக்கு வந்து 2-3 பேர் சூப்பர் ப்ரோக்ராம் நைஸ் ப்ரோக்ராம். முன்னாலாம் லாகின் பண்ணுறாங்கல்ல, இமேஜ் இருக்குது இல்லை மேலேயே முன்னாலேயே அதான் வரும் லாகின்.
நைஸ் ப்ரோக்ராம்னா ப்ரோக்ராமும் போடல
அதுக்கே
அவங்களுக்கு எல்லாமே இது பண்ணணும். கேஸ் வருங்க சார், பண்ண முடியாம முடிச்சுட்டு இருப்பானுங்க, ரெஃபரன்ஸ் வந்துடும். அதனால அவங்களுக்கு
அது ஆரம்பிக்கிறதுக்கு அப்புறம் தான் மற்றதுல எல்லாம் கமெண்ட் வருது. முன்னாலே அது மாதிரி
எல்லாமே எடுப்பான். ஆனால் போடணும். கட் பண்ணது இன்னும் கண்ட்ரி எல்லாம் வருது. முகாடிசு, அதுக்கு அல்ஜியர்ஸ் இருந்தெல்லாம் ஒருத்தன் லாகின் பண்ணி சார். அதுலேருந்து கொஞ்சம் எல்லாமே 3 நிமிஷம் சார். ஒரு 20 நிமிஷத்துல 5 ஐடியா காமிச்சார். அதையும் போட்டோம்னா பார்த்துக்கலாம்.
அதாவது அந்த ப்ரொவிஷியல் டெக்னிக்
காப்பி பண்ணுவோம்.
இப்போ ஒரே
ஆ
ಅಣ್ಣ ಎಲೆಕ್ಟ್ರಿಕ್ ಫಸ್ಟ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಲ್ಲ ಹಿಂಗೆ ಪಾರ್ಕ್ ಹೋಗಿದ್ದ ಹಿಂಗೆ ಪಾರ್ಕ್ ಹೋಗಿದ್ದ
போகிறோம்ல இந்த கேமராவுக்கா செவ் கலர் கேபிள் தான் இருக்குமே யூஎஸ்பி கேபிள் அது இதில் ஓ இல்லை ரைட் விடுங்க ஒன்று ஒன்று
Partha sir, hello.
சார் வாஷ்
Pasupati,
பண்ணிருக்காருங்க சார். சார் வாஷ் பண்ணிருக்காரு, 1 மினிட்ல வந்துடுவாருங்க சார்.
hello,
சார் கேட்குங்களா? ஹலோ
hello.
ஹலோ.
சார் என்ன கேட்குதுங்க சார்? எங்கடாங்க சார்?
அவர் கேட்கல போல இருக்கு.
ஏங்க சார், நான் ஒரு ஃபோனில் பேசிடுறேங்க சார்.
அது மியூட்ல இருக்கிற மாதிரி இருக்கு.
ஹலோ.
ஜெல்லி Hello.
Hello.
Yeah, Samrat Parsari here.
Yes, sir.
Welcome,
Morning, sir.
welcome, Samrat.
Yes, sir.
So this program was very hurriedly arranged. So only yesterday only I sent all the flyers,
Oh,
and thanks for the for your acceptance for this to chair this event. So I'm planning for 5 fistula surgery today.
that's
So I'm going to show all videos, all the surgeries. Each sometimes I used to get a different variety. One is the intersphincteric, transsphincteric, horseshoe shape, and anterior fistula. So like that. And today it is not like variety, but anyway, all case some interesting is there. So this is the female patient. You can appreciate here. And this slide போட்டுருங்க. So now I'm going to show the uh, transrectal ultrasound. Some cases I do MRI, and most of my cases I do transrectal ultrasound. And next slide. So this is a female patients, and past discharge almost for a month. And next slide. No comorbidities. And it is a 1 o'clock to 1 o'clock track around 3 to 3.5 centimeter distance, 4 centimeter. Next slide. This is the picture, and he has another track with a small cavity. So
yes.
that I couldn't palpate. It is on the left labia majora. So anyway, it is origin starting point is 1 o'clock. So I'm planning to ligate the track at the intersphincteric plate, and then if possible, I can able to access. I can able to go to that cavity.
Yes, sir. Yes, sir.
Okay. Okay. Next slide. Okay. Plan is lift. It is a transsphincteric fistula. Plan is lift. Yeah. So now,
Sir, this is a
and
prone.
yeah, the patient is in prone approach now. Patient is in prone, and you can see this is the anoscope. So all my cases I'm using this anoscope almost from 2012, almost 12 years now I'm using this scope. And many Indian companies they couldn't make it, but nowadays we can get this stainless steel cut anoscope. This cut length is 4.5 centimeter, and here also it is like obliquely cut, so that when you're introducing it, it will not injure the mucosa. Even a hemorrhoids or anything is there, mucosa will not be injured. And this has a conical tip with a solid. This is the solid metal portion. It has a central hole, so any gas fluid will come out. And because of this weight in the lower base, so once you place it inside in the anal canal and the lower rectum, it will stretch the anal mucosa and the lower rectal mucosa. So since the mucosa is stretched, we can able to identify the internal opening easily. And another thing, the patient is in supine, prone position, and you can see the buttocks is strapped. So I'm just covering with the sterile sheet. Can you see this plaster?
Yes, sir. Yes, sir.
Yeah. So with the plaster, I just strap it. So once you strap this, like still so this much traction should be there. Then only we can able to the muscle internal sphincter and external sphincter stretched, so that we can enter easily. So now I'm taking this anoscope. Since it is a 1 o'clock to 1 o'clock, external opening at 1 o'clock, internal at 1 o'clock. So I'm exposing 12 and 1 o'clock, and then I ask my assistant to lift like this, so that it will be more stretched. This area of track is being stretched.
Yeah.
That is the second point. Third one, now you can see this is the hole, but it is a little bit fused one here. Most of the time it will be active discharge. I'm just trying to make it whole. And this is the hydrogen peroxide, diluted one. I don't inject methylene blue. It will spoil the field. And hydrogen peroxide, even a very small hole, sometimes the internal opening is occluded with the food particle. That also will be, this hydrogen peroxide will penetrate. So I'm not able to see the internal opening.
Maybe obliterated internal opening.
Yeah. Sometimes it will be obliterated. So how is the vision, Samrat?
Absolutely fantastic, sir.
Okay.
Great. Sir, for the benefit of audience, you can tell which o'clock we are doing, so that they will get
Right.
oriented.
Which one, Samrat?
O'clock, sir. Clock position, sir. So
Yeah,
that
yeah.
they get a
See,
orientation.
yeah, the patient is in prone. This is, you can see, this is the coccyx, no, sacrum, coccyx here. So this is the 6 o'clock.
Yes, sir.
And then this is the 12 o'clock.
Yeah.
And this is a female patient, this is the perineal body.
Yes.
And you can see this is the external opening at 1 o'clock. So this is the
Yeah.
external opening at 1 o'clock.
Yes, sir.
6, 12, 3, 9.
Yes, sir.
Okay, no, yeah, 12, 3, 6, 9, like this.
Yes, sir. Yes, sir.
Yeah. And any fistula in female, it comes under anterior fistula in female comes under complex category.
Yes, sir. Yes, sir.
Most of the time it will be in transsphincteric, and even if it is intersphincteric, it will come as a complex, because no anterior fistula in females, and postoperatively sometimes no wound management is difficult. And you
Yes.
can see the perineal body is around 11 mm to 13 mm in most of the patients, and we have to open. This is the, you can appreciate very well. This is the mucocutaneous junction. This is the
Yes.
skin, and then mucocutaneous junction is here. So we have to open at the level of, so some superficial fistula I can able to feel the track, and according to the scan, I'll show the scan report in the video. Usually this, I ask the radiologist whether the track is the intersphincteric track is a matured or not.
Yes.
They should see the fibrous track in the ultrasound wise or a MRI wise. If it is a mature track, then only I go for a lift. Otherwise, lift will be failure.
Yes.
So in this case, they mentioned mature around 4 to 5 mm thickness.
Yes.
So but I couldn't feel it because it is a deep to the muscle.
Yes. Might be because that cavity things didn't came
Yeah,
on. That.
maybe here cavity must be here.
Yes.
This is the track. Cavity must be here.
Yes, sir. Yes,
So
sir.
I'm going in the I should not go in the very close to the anus, and always you find out the mucocutaneous junction here and here, and then I'm opening here.
Yes.
So you have to make a skin incision at the mucocutaneous junction 1 to 2 mm away from the mucocutaneous junction, and you can see I'm using this tungsten tip. You can see this is the high vascular area, but
Yes.
I'm using only the monopolar cautery, but you cannot see any bleeding because
sir.
of this tip. The focus பண்ணிக்காம. Yeah, so this is the tungsten tip. Now the Stryker company, they are having distributing this. This is one of the very finest one.
Yes.
And for this type of incident, hereafter I am using the regular tip come with the cautery. Yeah. So this is the retractor designed by Rajanaskal. It's like a copper S-shaped retractor, and any copper retractor you can bend like this. Only thing, this should be very small. It should be more means very difficult. The bend is very small bend, and it's very strong. So
Yes.
what you know, each fiber by fiber you can retract, and then you can able to enter with the intersphincteric plane with this retractor. Don't leave this. Now you can see my assistant is retracting this, and then is going to retract this place, and then here I want to some more stage. So my staff nurse is stretching this so that so that you can see the entire area is stretched. So this is very, very important. So if it not stretched means you will go into the wrong plane. And you can see I'm not going to this because divided edge, skin divided. I'm going to the proximal divided one. I'm not going to this here. This means I enter into the external sphincter.
Yes, sir.
Usually we could able to see the fatty, one small fat intersphincteric plane, some fatty tissue will be there. Always internal sphincter thickness is very small. So now you can see this is the external muscle. I cannot go here. Again, I'm trying to separate this muscle. Some patients it will open easily, some patients it's difficult.
Yes.
Yeah. Any questions or any doubt?
Nothing, sir. Vision is very good, sir. Vision is
Okay, okay. So since it's 1 o'clock, my concentration here, still I'm not getting that exact intersphincteric plane here. So I'm going to, for exposure purpose, I'm trying to make here some more incision. And anywhere if you feel some fibrosis, then you can adherent to this fibrous plane, so you can able to get the track.
Yes, sir.
With the cautery itself, it is like a probe, so you can palpating the fibrous area. நல்லா எடுத்துட்டு கூடாது, அப்படி இல்லை கீழே அழுத்தக்கூடாது. See, you have to இப்படி தான் பண்ணணும், இப்படி தான் பண்ணணும். So still this case I am not getting the exact plane. See, now I am just retracting this area because of the fibros of the track. The muscle is not able to separable.
Yes, sir. Yes, sir.
Are you able to follow? தூக்காதடா, அங்கே மறைக்கணும். சரியா, அதுக்கு இப்படி 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 ட்ராக் பண்ண சொல்றேன். நீ பிடிக்கிறத இங்கே பிடிக்கணும், நீ பிடிச்சதே தப்பு. இப்படி இப்படி. Still I couldn't able to find out the track because there is no fibrous structure I am palpable. I'm not able to palpate any structure. Nalla stretch. It must be here.
Yes, it's appearing like some fibrosis.
Yeah, some area.
And it is at 1 o'clock, sir.
Yeah, it is at 1 o'clock.
Yeah, it is most probably that is a track, sir.
Still I am not convinced somewhere, because it is not that much mature track. I am not able to palpate. And even hydrogen peroxide comes means I could able to confirm.
Yes, sir.
But
yes,
today
sir.
I am not able to confirm that also.
Because of secondary extension and cavity, that
Yes,
all has gone on that side.
Yes.
Anything you palpate on medial side, sir, internal opening, sir?
So now can you find out the plane? This is the
Yes,
internal and external.
Reservascular nice plane is seeing, sir.
Yeah, here it is a nice plane.
Yes,
12
sir.
o'clock position, it is nice plane is opening up. And in female patient, no perineal body, you have to be very careful.
Yes, sir.
Otherwise you will injure the vaginal wall, or you will enter into the anal canal or rectum. Can you see this area? This must
Yes,
be the track.
most probably that appearing track, sir.
Yeah.
Might be because of inflammation, the plates are not very good, sir.
Yes. But if you are patiently doing, you can able to get a plane.
This is not a routine.
So the track is here. It's a fibrous structure is deep down, deeply there. So I'm just dividing this one. This is the one previously we thought it is a track.
Yes, sir.
Gas facial forces. I could able to see the track very deeply. இது தூக்கக்கூடாது, அந்த மாதிரி கான்சென்ட்ரேட் பண்ண, இல்லைன்னா வீடியோவில் தெரியும். ஓகே. Since it is a transsphincteric means we have to expect the deep track.
Yes, sir. Yes, sir.
And most of the time the imaging will give 1 centimeter or 1.5, but it will be more than that.
Yes, sir.
What we are feeling during surgery, what we feel is more deeper structure track.
Good afternoon, Partha sir.
Pinak, yeah. Welcome, Pinak.
Yeah, I was watching.
Thank you for accepting in a very short notice. And
Pleasure, sir. Pleasure. Always to watch your surgery. So this is an anterior fistula, right?
Yeah, this is the anterior fistula female patient, and it is a transsphincteric. You can see this is the external sphincter. Entire external sphincter is retracted here. I am retracting the internal sphincter. The track is appearing here.
Yeah.
So first I am going on the other side, right side of the track.
It's opening at 6 o'clock. Sorry, 12
yeah,
o'clock.
Opening at 1 o'clock.
1 o'clock.
Yeah, opening at this is the opening, 1 o'clock opening. Patient is in prone, so that is a 1 o'clock opening.
Okay.
Bipolar small bleeder from the tract.
Do you put any methylene blue so that by
Yeah,
mistake?
usually no. Initially, I start with methylene blue. Maybe some beginners it will be useful, but nowadays no, that will spoil the feel. So now I'm using hydrogen peroxide.
Okay.
And this case, hydrogen peroxide is not, that is also not working. Maybe the obstructed internal opening.
Yeah, there might be potentially blocked one, sir.
Yeah, and if it is a hydrogen peroxide is working means then it is be nice. Now after ligating, I can able to again inject the hydrogen peroxide, so it will be more convincing when you watch the videos or surgeries. Then you will more convinced that your tract is being ligated. But today that I cannot able to do it. But anyway, after ligation also again I can inject the hydrogen peroxide. If it is coming through this divided end, then that is also confirmation. So
Yes.
can you see here this side I went little deeper. Can you
Yes.
appreciate?
Yes.
Yeah.
There is a so I go deep. Some more depth now I have to go. So I'm planning to I'm going to this side.
Hi, Samrat.
Hi. It's a beautiful vision.
Yeah.
Yeah, because
Very
I'm not
difficult.
using a Zoom platform or any other team or any other thing routinely used for this no online meeting. This is our own way we are making it with the Venkat sir, no, the team.
Every fiber of external sphincter can be appreciated very well.
Okay.
Even if we want to do the surgery, we can't see this
Bye
kind
bye.
of vision.
If you're watching in watching in a bigger screen, no, it will be more enjoyable. Yeah.
Yeah.
Almost it is a very deep one,
Yes, sir. Yes, sir.
and entire crossing the entire sphincter, external sphincter. So I'm trying to go on the other side of the track. Can you see I'm going deep?
Yes, sir.
So you are isolating the tract from both the sides.
Yeah, both the sides. Again, I'm coming to this side. If you go deep, then you will expect some bleeding, because of the deeper muscle vessels will be there. So I'm using a right angle. It is a little large angle, no right angle. I'm using it. If it is a superficial track, I use a smaller one. Here I'm going on one side of the track. And the can you see my instrument is no still it is tip is not coming.
Yeah, some
Some
more
tissue
tissue
is
is
there.
left there.
Yeah, I just cut this tissue. பிடிச்சுக்க sister. வராது சக்சன் குறுக்க வராது.
Sir,
So I
have you
open.
added any modification to the
இது
conventional, like
மட்டும்
whatever you are demonstrating is the conventional lift procedure?
yeah, it is a conventional lift. I'm not doing any பிடிச்சுக்க. And some long track, no long track. After division, I started using no few cases. இதற்கு sister. Few cases I'm using laser to ablate the track.
Okay, the long,
DLPL, no, the yeah, distal
yeah, distal.
laser, proximal lift, that kind of thing.
Yeah,
And most of my cases is a conventional. I'm not, no, I tried all the modification, no,
yeah.
but I'm not much convinced about that. Since we can able to do a nice work with the conventional lift, so I thought of continuing the same.
Okay, okay. And what do you do with the internal opening?
Yeah, internal opening, I'm not doing anything. I
Okay, the
ligate
same
the track.
ligating it
Yeah,
at the internal.
ligation since it is a deeper. Imagine, no, this track. If you want to ligate a simple or a transfixation suture, it is difficult.
Yes.
It's very deep. Otherwise, you have to make the incision more. So that's why I'm doing this endo
Endo,
loop.
endo
Yeah,
loop.
and this is it is not a transfixation. It's just a ligating loop. but it is a mechanical tightening, no?
Yeah, yeah.
I'm tightened with the this one plastic rod. இது பிடிச்சிக்கிறேன். இல்ல இது வைக்ரல்ங்க 10. Now I'm using 10 வைக்ரல்.
So this
So I'm
is a
trying
quite
to push the thread close to the internal opening.
Yes,
yeah,
sir.
yeah. So this tract is very thick and fibrous. So
Yeah.
you can comfortably place a loop. Sometimes we find the tract will be very friable.
Yeah, so that's what I told in the beginning of my starting the surgery. I used to do the transrectal ultrasound and some cases MRI. The main, what are the findings I want is whether it is no, internal opening. I have to identify the internal opening, which level, what is the which position, and then how much deep. Second thing is, second thing is maturity of the track.
Yes, sir.
If it is an intersphincteric tract is matured, that is a fibrous tract, they could able to feel through ultrasound, see through ultrasound. Then I advise for lift.
Okay.
Third one is any intersphincteric abscess.
Yeah.
Can you see this external muscle sphincter?
Yes,
Yeah,
sir.
yeah, yeah.
Nice.
Yeah. Suck பண்ணு, நல்லா குவிஞ்சு பார்க்கணும். So the now what I did, already loop is applied. So now I'm trying to make one transfixation suture. So that it will be like a double protection. Since I'm not divide the track, so that the instrument is helping me to lift the track. See, very difficult to reach that place.
Yeah. So what I do is we use that 5/8 circle needle, which will be
Which one?
very 5/8 circle needle. This is half
Okay,
circle
okay,
needle.
okay, okay. Yeah,
So
yeah, that is ideal.
manipulating
This
this
is half
is
circle. Yeah,
very
yeah,
difficult.
yeah.
So
So I
5/8.
take and keep. Now I'm including some internal sphincter. Can you appreciate this internal sphincter?
Yeah, yeah,
I'm
yeah.
taking a stitch so that it will hold the stitch in that place. Yeah. So that will be there. After I tighten this, divide this track first with the endo loop. That is a more secured one. Again, I tighten here. So I'm going to divide the track now.
Yes, sir.
Okay.
So here the opening is around 1.5 to 2 centimeter, but you can see the 6 hands is working in that place.
Hmm.
That's why everybody should be oriented, and then it should not be vision also should not be hidden. Should not be no one should hide the vision, so that otherwise you will not see the structure. Clean, la? It's clear. Okay. So now I'm going to divide the track, and for this I'm having this another. You can see the same one, but it's little bent. Can you see? Either focus பண்றாங்க.
Okay, that pin type
Zoom பண்ணு.
needle type cautery.
இதை zoom பண்றா. Yeah, it is like a small bend.
Yeah.
Okay,
Right.
even a straight also you can use, but posterior, no, anterior part of the track you find difficult. So I'm making by this one same cost. So now I'm going to divide this track, and most of the time you will see this opening, the opening here. Suck பண்ணு நல்லா. It looks like small opening here,
Yeah.
but it is not much very obvious this case. Yes, suck பண்ணு. If it is not fibrous track, it will be cut through.
Yes.
So if you're not hooking the track, now you can appreciate. No, after division of the track, again I'm tightening. See
Yes.
what happened? You are making the you are stretching the track. Then you stretch the track and then you are dividing it. No, that will not have a good tight. So after tighten again I just curate after division of the track again I'm tightening that, and since it's a very deep, some bleeding is expected. Suck பண்ணு. நீ வாங்கி பண்ணு. கொடு. இங்க இருக்கு இங்க.
The gas electric.
சக் பண்ண அது ப்ளீட் இருந்த பிளட் இருந்த பைப்போலர் வராது. பண்ணு. எடு. சக் பண்ணு.
Every fistula case comes with always different challenges, sir.
Yeah. So now I'm trying to inject hydrogen peroxide. Whether it is coming through this divided end, that means it is I ligate. I divided the track.
Yes, sir.
Because here itself I'm not able to go. Gas. So it is coming through vagina.
Yeah.
Oh,
See, here also coming, there
you are
also.
also coming.
But why it is coming through vagina, I don't know.
That what he has shown the cavity, sir, that might be possibility, sir.
Yeah. Okay. I just ligating this one.
Yes, sir.
அது எடுத்துற. இது retract. எப்படி. Okay. Might be some injury, we have to check. இது பிடிச்சுக்க. சலைன் கொடு. I couldn't see any hole or things. I'm feeling also I'm not seeing anything. Okay. Okay. So hereafter, I have to open this. Try to exercise the track traveling through the sphincter.
Yes.
Bipolar.
So you will just widen the mouth, or you will excise till the external sphincter?
Yeah, I just make incision around the opening, and most of the time the opening is it will go around 1 centimeter in the subcutaneous plane, 1 to 1.5 centimeter. Then it will enter into the sphincter.
Okay.
See, can you see it is traveling in the subcutaneous?
Yes.
It will not piercing the sphincter 90 degree always, any case. It will be go in the oblique track, end with the oblique track only. As much as possible, I am going along close to the track. Inga retract pannu. Chalice kodu. I'm trying to expect this another track here according to the scan. Can you see no very thick fibrous track? So it is going. So now the sphincter muscle is getting appeared. Can you see this muscle?
Yeah, the external
This is the
sphincter.
muscle. So we have to go very close to the track, separating the muscle from the track without injuring the muscle. When you are going deep, it will be bleeding will be expected. Cut பண்ணிட்டாங்க நல்லா. பைபோலர் இன்க்ரீஸ் பண்ணு, சரியா வர மாட்டேங்குது. வரல, நல்லா செக் பண்ணிக்கோங்க. வேற ஃபோர்ஸஸ் மாற்றி பைபோலர் வச்சோன்னு வரணும்ல மெதுவாக.
Welcome, Dr. Balu.
Yeah.
Hello, Pinar.
Yeah, Balu, welcome.
Sir, thank you, sir. Sorry, sir, I was in a case.
Thanks for acceptance. Yeah, okay. This case is going to get over now.
Okay,
And
sir.
I have to check this post-vaginal wall at the end of the surgery.
Yeah. That,
Bipolar. Bipolar. And particularly female patient, anterior fistula, and this type of transplanting, no, it will be very much vascular near the muscle area. The labia area, no, it's very much vascular. So the track is totally, can you see, no, I can able to almost enter below the muscle, I track went, and I excise the track, almost completely excised, and this is the divided end of the track. I'm just introducing the forceps here. So I'm just that will be the defect in the sphincter. It is not injury, that is a defect. I can able to close this.
What is your preferred suture for a sphincter closure, sir? For the external sphincter closure?
I'm using 20 vicryl only.
Okay.
So there is no hole. Can you see here? I'm just there is no hole. I don't know how it is coming through vagina. Maybe this may be communicate. I don't know.
Sir, that might be another one cavity which has.
Yeah, there is a cavity was there.
Yes.
Here I could see some granulation tissues, but anyway, I'm going to close this with the vicryl. That's why you may enter into the vaginal wall. If it is happen, if you are entering the vaginal wall, if you are able to see the hole, then you turn the patient to lithotomy and then you suture the vaginal wall, and nothing will happen. But here I'm not able to enter. I'm not able to. I cannot see any hole or something. Maybe that white track, no, that may be communicate with the vagina. So I'm just checking for any defect or any hole. So I'm not seeing anything. So I'm started suturing just below the muscle. I'm taking a stitch with a 20 vicryl.
So you are probably doing the rectovaginal septum suturing now.
Yeah,
sir?
that may be. Yeah, I'm just suturing the septum. That's all. Maybe some very minute hole or something. That is the reason for his hydrogen peroxide is coming there. So that will be blocked by this suture. Not 3, not 4. But it is a very deep transphinctry. No other option. Suck. Forceps. Suck.
some amount of external sphincter is also taken, no?
Yeah, some external sphincter, no, because the track is
That will
going there.
reinforce it.
Yeah. Traction study. Every way done. Yes. Very small opening, so taking bite, everything will be difficult. If you find difficult, you can extend the incision. Initially, I took this sphincter fiber. Now I am not taking the sphincter. Suction. Nala suction. So still, I'm now some fiber is there. I'm taking the sphincter fiber. But in this case, if you see preoperatively, doesn't look this much difficult, no?
Yes, sir.
Not workable.
It was appearing low fistula only, sir. Small
Yeah,
and
yeah.
low fistula.
And scan wise also it shows only around a centimeter, 2 centimeter depth, but it is
Yes.
fully transsphincteric, so much depth.
Yes.
Most of the case will be like this, no? Even MRI, anything, it will not show the correct the picture, no? Correct picture, what is inside. But if you are in a right plane, you can able to reach the base. Light attraction. Forceps. So what are the what are you following? Now one of you Samrot, Pinak, and Balu. You are following only one procedure for fistula, or
No,
what
sir.
is your most
It-
of the cases what you are doing?
Yeah, so probably most of the
Commonest
cases
procedure for fistula what you are doing?
lift with modification. I won't
Okay.
say classical lift. Many times we tend to excise that internal opening and
Okay.
marsupialize.
Yeah.
So Samrat has popularized one procedure,
Yeah.
Piltek
Samrat
procedure.
popularized the technique. That is for maybe even a deeper opening, deeper fistula, internal opening, more above the indentate line. Also, you are doing it, or
No, sir. What actually happened is, sir, multiple time while doing lift, was having a trouble that medially sometime there is a sphincter injury, sometime mucosal injury. So
yeah,
over,
yeah.
I just seen that healing on the medial side was happening good. So
Okay,
I made initial first step as a intersphincteric dissection, sir, and later on I divide a internal opening and internal sphincter beyond the internal opening, sir.
okay.
Yeah, it is kind of lift only, sir. Some little
Yeah,
bit.
yeah, you showed no on that Balu conference.
Yes, sir.
Not very nice. Yeah.
Yes, sir. Yes, sir. We had a exposure of this intersphincteric space and learning from you, sir.
No.
Sir, my practice
Okay.
is slightly tailored. Whenever
Okay.
there is any
Better.
active sepsis, I don't
Specialist.
do anything which closes the tract or the sphincter. So my preference is to do a fistulotomy, fistulectomy, or even do a lift, leave the intersphincteric space open if it is an active infection. And if I do it in periphery, which I do quite some time, about 20% of my practice is outside PhD when it comes to fistula. There, because the follow-up is not very stringent, I prefer to do a fistulotomy or a fistulectomy in patients where the sphincter is not a threat. But in PhD, my preference is to do a lift with a modification. I
Okay.
also use WAFT.
For WAPT also you are using.
Yes, sir. Long tracks instead of just curating and
Yeah,
leaving them, I try
straight
to
and
use a
long
WAFT.
track you can use WAPT. Yeah.
Yes.
So I tried that one initially WAPT, then I changed to lift, and since no conventional way I'm doing it, I'm happy in that in this lift. Only thing, pre-operatively I checked whether the track is mature or not. If track is not mature, then I tell the patient to wait for some time. The patient is telling very symptomatic, I can't wait. Then I go for a fistulotomy or fistulectomy. Depends on the case.
Okay.
Strap.
Low
Uh,
fistulas, perhaps fistulotomy is uh, always like recurrence will be the least with
yeah.
a
Yeah. See,
Yeah.
we
For
make
all
it.
low fistulas, my preference is yes.
We are making the patient from the condition now at least relief of some symptom. If later on if it comes, then we can go for lift. That's why lift is not meant for all cases, but you have to prepare the case for lift.
Yes.
You have to educate the patient, and then no, then with some antibiotics, some local dressing, we can wait for some time, then we can go. Now you can see this is the position of the normal position without strapping.
Yeah.
Can you see how much we exposed with the strapping? Okay.
Very important step, sir. Next
Yeah.
case, we can show that strapping. How can
Yeah.
you do, sir?
Yeah, I think next case is induced there.
Yes, sir.
I'll show in a third other cases. Yeah.
Yes, sir. Definitely. Sir.
I'm not taking the muscle, only the skin. No, I'm taking just for 2 interrupted stitches. This I tried no all subcuticular, continuous, and then the simple suture. Finally, no, all is giving way, and then this interrupted mattress is better. Only the skin. So nowadays I'm using this. This is the 2 Vicryl. I used to see follow for a first week of surgery and then first month of surgery. And when the patient comes for first month, it will fall off automatically. Some patients, no, a wound is healed and will be there, suture will be there. And then I remove the suture when the patient comes for the second review. That is 1 month after surgery. And I'm expecting some, instead of ligating like this in a very deep track, so I thought of I thought of applying clip, locking clip, no hemolock clip, but hemolock is now we have only the plastic clip. We already companies having a PDS hemolock, no locking clip, observable locking clip that is not available. Maybe if I get this clip, no, that may be the another option. You can just apply clip and then we can come out.
Yes.
And the excision of this cryptoglandular part, when the now the even Arun Rajanaskal also this modified way he is doing. But what I feel in my cases, no, most of the time I'm not touching anything on the transanal side. And initial concept was we have to excise the cryptoglandular that part, so that infection rate will be less. But here I'm not doing this, but anyway the healing rate is good.
Yeah. But in lift, it is very good that the wound is closed, wound will heal better, and patient pain is less. And
Yeah.
if doing the fistula procedure, lift has to be learned, because by learning the lift, you will know the intersphincteric space and all the thing, and then only anything can be done. Lift is one of the mandatory procedure after fistulotomy. Someone is doing lift has to be done, because it will save us in height fistula, sir.
Yes, sir. See, this external opening also I'm going to close.
Yes.
Because I excise the track, I leave small gap. Maybe from the cavity something is coming, then we can able to put some tube. We can able to wash. I'm not keeping any drain for this patient. Just I'm making a simple mattress suture. So I leave with the one suture, so that gap will be there to drain some fluid or wash can be given through the gap. I'm not feeling any injury or anything in the post-vaginal wall. But anyway, no, I turn the patient. I'll see once again. Okay.
Yes.
Okay. With this, I'll finish this case. Any discussion, any doubt or anything you can manage, or we'll go for the next case.
So do you always close that external opening, because that is?
Yeah, the external opening closer also. You can see some gap. I keep it for wash, and sometimes I close fully. If I access that completely, there is no doubt. And here some another track is going on with a small cavity. That's why I opened this for post-operative wash. Otherwise, you can close it. No, automatically the healing rate is good. When the patient comes for first review on one first week or 10th day, the complete external opening part will be closed. The lift wound will take 2 to 3 weeks time to close. The external opening just skin and subcutaneous tissue, it will be closed fast. Okay, just I keep a small no betadine soaked gauze piece, ointment soaked gauze piece, and over that we'll put a pad and we'll put a plaster. We don't put this the bandage, like. And this patient I
Bandage.
catheterized anterior fistula, female. I catheterized at least for 1 day, and then tomorrow I'll remove the catheter. So 1 day the dressing will not get soaked, and then I'll educate the patient tomorrow how to clean that area. The sits bath,
Sir,
etc. We have to explain
antibiotics,
properly.
antibiotic.
Antibiotic ofloxacin or ornidazole for first week, all cases, and then second week when the patient comes, I used to put this one, no, third generation cephalosporin, 2 antibiotic. And many surgeons they used to tell after surgery fistulectomy, I don't put antibiotic. No, I'm putting antibiotic 10 days. First 5 days for Ornof, that is Auflux ornidazole. Second 5 days for third generation, no, so cepodoxime.
It's
Sir,
always better. Always better.
Yeah.
Do you advise any restriction on squatting
What
in these patients like you do a fistulectomy primary repair, sir?
No, I don't restrict on squatting. Because most of the patients they are not using a squatting position. They are not using, and they are going for a Western toilet. And we have that good sits bath device. Initially, like a small chair. Now I saw it is only the small, like a device. You can keep it over your closet, your Western toilet, and then it will give a
Yes,
very
sir.
nice, foundation.
And it's
Yeah.
easily available
So,
even in Amazon for
yeah,
800 rupees,
everybody,
900
even
rupees.
Amazon is there, and it has
All our
three types
patients.
of flow. For anterior and posterior, the flow will be different. You can set accordingly, so that patient will be more comfortable. The way of switching. So the squatting, it is not actually for at least for 10 days. It is not advisable. But most of the patients they are not doing squatting. Yeah.
Right, sir. So now it has also become routine for us. For every patient who goes home, one donut pillow and one sits bath
Yeah.
tub from Amazon or Flipkart they order when they get admitted. So when they go home, they get it delivered and they do that sits bath with the sits bath tub. Not very
Yeah,
expensive.
and most of the
Good
time
for
they're coming with a donut pillow because they're already educated by a local surgeon, and then they know about sits bath. They have a pillow, and then only thing the diet advice is very important for a high fiber diet. And I used to tell my patient to avoid maida as no even a lifetime. Maida product, no biscuit, bun, bread, parota, from all I used to tell. That is the one is not good. Otherwise, healing rate is so good with the lift surgery.
Yes.
Even though a lot of handling, you can see the post-operatively pain is so less because I'm not touching the anal canal. Mucosa is not disturbed. Below the mucosa structure is not disturbed, and it's going away from the anal mucosa. So most of the patients they don't feel pain post-operatively. Can I go
What
for
about
next?
Thank you, sir.
laxative of your
Please.
Yeah,
choice?
yeah, laxative definitely for at least 3 weeks. I used to give a laxative. I'm using a lactulose syrup.
Yes.
Initially, I tried powder and all, but now I advise only lactulose syrup for daily 15 ml at night, 1 hour after dinner for 3 weeks.
Okay.
And mainly we have to educate the six bath how to do. And then now I read a old article. That article they mention, sorry, not article, it's a book. They mention six bath to be taken at least 30 minutes and 10 minutes with 40-degree temperature. We can measure with the temperature probe, and then next 10 minutes 45-degree temperature, and then next 10 minutes 50-degree temperature. I don't know 50-degree how much it is possible, but that is the way we have to take the sitz bath. 30 minutes we have to take 40, 45 degree and 50 degree. And I used to tell each 10 each time, not 20 minutes you have to sit, and then 40 times you have to contract and relax the sphincter so that water will go in and out. That is also one way. It's, clean anal canal should be there. எவ்வளோ 2 minutes ஆகுமா 5 minutes? Yeah, I'll have a we have to set this entire unit to the other OT.
Yes.
We'll have a 2 minutes break if possible. That time I'll play some videos possible. Okay, so within 2 minutes I'll connect you again.
Okay, sir. Okay.
Okay, and meanwhile okay, இல்லை எப்போ லைவ் சரி ஓகே அங்கே ரெடியாக இருக்கா எப்படி இருந்தாலும் நான் போய் வாஷ் பண்ணுவேன் கேஸுக்கு வாஷ் பண்ணுவேன் ஓ யூ கேன் டிஸ்கஸ் வித் யுவர் செல்ஃப்
Yes.
all of you three will be in the online only so that audience will be benefited with your knowledge. You can discuss and within 3 minutes I'll connect to other surgery within
Yes.
3 minutes. Okay, yeah, okay, thank you.
Pinnack, sir.
Hello.
Tell me, sir.
No, Samrat. No, I think we are waiting for the second case, correct?
Hello.
Samrat. Hi, Samrat.
Pinnack, sir.
Hello, Samrat.
Voice illa.
Voice is not there? My voice is on only. Audible? Am I audible?
Yes, you are audible.
Sound illa.
Pinnack is audible.
But other means they are not able to hear me. Samrat, you are able to hear me?
So Pinnack, you are audible.
Yeah, hi sir, hi.
Yeah.
எப்படி இருக்கீங்க? டிரான்ஸ்மிஷன் நல்லா தான் இருக்கு.
நல்லா தான் இருக்கும். அதுக்கு தானே பண்றோம்.
அதான்.
Samrat, are you audible?
Samrat, you are using mic or what? Samrat? Samrat? Samrat's audio? Hey, Balu.
Yes, Pinak sir.
Yeah. So I think Samrat's this thing audio was having some issue.
Okay.
Okay. Okay.
Now it is clear. Yeah.
Yeah.
So today free day, huh?
No, I actually cancelled one case today. Sir suddenly called yesterday afternoon. So morning we had one, but the afternoon case I postponed to tomorrow.
My OPD day today, so I
Oh,
asked that
okay.
him to see.
Now you have a big team.
Dada is having big team.
Will this
Today,
be streamed? This is not getting streamed, no?
I don't know.
Mostly.
I maybe say
Yeah,
we
keep quiet.
discuss something. We discuss
Yes.
academic things.
Anterior fistula in female usually complicated, and sir,
Yeah, by definition itself, it is complex fistula.
the external sphincter is thin, and damage may come with incontinence. And also, sir has a complicated case where deep track and other thing is one was track and there was also cavity. So because of that, it added lot of complexity.
Hmm. And if the means old females multiparous, they will have a very thin rectovaginal septum.
Yeah.
So while dissecting that tract, doing an intersphincteric dissection, we talk about spaces, but there is hardly like is few millimeters only.
These are
Pinaka,
all potential spaces. Potential spaces.
I
Yeah.
have a patient currently in my ward. She's a young female, no vaginal or perineal procedures, bicornuate uterus, infertility treatment. She underwent an INT for perineal abscess before 4 months. And she developed a rectovaginal fistula. It's a small rectovaginal fistula. Infertility specialist sent back to me saying that you have to sort it out before you do it. I think the next case is ready. So we
Yeah.
actually did modified Martius flap, and it was a
Okay.
half centimeter opening, but there was a slightly bigger cavity down. So standard modified Martius. In fact, I recorded it. I was so happy. Only thing I used 1 in 50,000 Zalakin adrenaline. I think we'll stop the discussion. Sir is ready with the case. Yeah.
So again, an anterior fistula, I think.
Probably, sir.
மோஸ்ட்லி வந்து அந்த எம்ஆர்ஐ இதெல்லாம் சும்மா ஒரு இன்ஃபர்மேஷனுக்கு தான். உங்கள் பெரக்கல் எக்ஸாமினேஷன்
ஆமாம் அதுதான் மெயின் சார்.
பொறுமையாக பண்ணி எல்லாம் கரெக்டாக பண்ணி அந்த நான் வந்து என்ன பண்ணுவேன் 1 o'clock வந்ததுன்னா அப்படி வச்சு அழுத்துவேன். இன்டர்வேஷன் அழுத்துனா ஆன் கத்து பெயின் அதான் பெயின். அப்புறம் அதே மாதிரி இப்போ இங்கே அழுத்துறேன் இங்கே
Partha sir?
பின்னாக்.
Again, one anterior fistula.
Yeah, it is again anterior fistula in the male patient. It is at 11 o'clock.
Okay. And there is
Patient
some
is in prone.
small redness at.
Yeah, here is there, in the anal
Yeah.
wedge. And here, just I saw the transrectal ultrasound, also coming sister. And they mentioned around 1.5 centimeter depth. And in the intersphincteric, they mentioned as an intersphincteric, you can see the pus.
Yeah, pus pouring out.
வேணாம் வேணாம் விடு கொடு கல்ச்சர் வேணா எடுத்து. அண்ட் இது சோமி த ரிப்போர்ட் ஸ்கேன் ரிப்போர்ட் they mentioned 5 mm depth the track. This is the way, no, usually the transrectal ultrasound they'll give only 2 or 3 lines, but I want like this. I talked to my radiologist, they used to give me like this.
Yes.
whether intersphincteric tract, any abscess is there or not. He even in the last line they mentioned no collection within the tract. So that's what I want. Any tract, any collection in the intersphincteric plane, that then lift is not advisable. And the immature tract, again lift is not advisable. So only thing, three things I want. One is any collection, intersphincteric collection, or a mature tract or immature tract. Then internal opening, how much depth and which position. So these 4 points, if you get from a good radiologist from transrectal ultrasound, and then MRI is also giving you the same. And if it is a very deep, then I will go for a MRI, very deep internal opening or surrounding abscess. Then I will go for a MRI. இல்ல இது கூட artery கூட first.
Internal opening is palpable, sir. Any induration or internal opening?
Most of the cases it is palpable, not for all cases, but some cases, that's why I told, some cases it will be flat, but you will get a tenderness there.
Yes.
You can just press that level, you will feel a tenderness. Can you see it is opening here and there?
Yeah.
It is coming here and then it is opening inside also. Track is coming like this. This may be some abscess and then it's open here.
Yes.
Yeah, probably it was an abscess and then again that closed and this one opened up. So that same tract has multiple external opening.
Yeah, same tract, multiple external opening. But anyway, this is at the level of mucocutaneous junction. I'm going here and I have to find out the track without damaging it. That is a good thing. Yeah? The track is at 12 o'clock. If you see the pus means some collection is there. Without cavity, pus will not be there. Otherwise, it will be drained out. So again, you can see this skin and mucocutaneous junction level. So what I do, I'm just opening here. So the same level where I want to open this another external opening is there.
That might be low intersphincteric external opening.
Yeah, that is that intersphincteric area. It is there.
Yeah. The tract might be at 12 o'clock and there is intersphincteric opening and then transsphincteric opening might be, sir.
Saturday.
According to scan, it is intersphincteric. Light எங்கேயோ இருந்து அடிக்குது சிஸ்டர், இங்க மேல இருந்து அடிக்குது. கொஞ்சம் நகர்த்திக்கடா கேமரா. 1 minute, I'll adjust the light. Yes.
The tract is intersphincteric?
Yeah, they according to scan they mentioned it is intersphincteric.
Yeah.
I have to check. Yes, Balu. Yeah. So now I'm going in the intersphincteric plane. I'm making little wider incision here. Can you see this internal sphincter is getting separated?
Yeah.
Bleed retract தான் பண்ணணும்டா, நீ சக்கணும் அவங்க இருக்காங்க.
சக்கன் கொஞ்சம் பாருமா சிஸ்டர்.
Come here. So the traction is very important. Inga kai vai sister. See, first thing is traction is important one. Second thing, you just if you are in a right plane. So now this is the internal sphincter, external sphincter is this side. So I'm going here. If you see muscle fiber, then don't divide with your forceps or cautery. Then you can try to identify the plane, then you can go. Can you see this is only the fatty things. சின்ன செக்ஷன் வச்சு பண்ணு sister. Can you see this muscle here, external muscle?
Yeah, yeah.
Clear? Yeah, okay. I could see the fibrous structure. Can you, are you able to feel it when I'm moving the instrument?
Yeah, we can appreciate that
Yeah,
fibers is here.
it's able to feel that fibrous thing.
That yellowish whitish thing is
Yeah, yeah. So I'm going deep to the track. So the traction is very important here. Otherwise, no, you have to use more cautery to divide the tissue. Okay, so now I'm going on the other side. ஏ உனக்கு விஷன் ப்ராப்ளம் தான் சொல்லு, இது தூக்காது. சார் கொடு கொடு கொடு.
In redo lifts, how easy is it to get into the right plane, sir?
Yeah,
What is
see,
the trick to
when
identify the
I
plane?
have yeah, I have around a few number of cases. I have done 3 times lift, 3 times lift, and initially I thought it is difficult because of fibrosis. I put a mitral suture, but we can able to enter into the plane. I don't find any difficult. Again, the exposure is the main key role with the strapping. Next case வந்து strapping மட்டும் photo எடுத்து காமிக்க சொல்லி மறக்காம. So initially all cases, I don't believe anybody. I used to go and then I strap the patient. Now my team is getting trained. Even staff nurse, anyone is there in that OT, they can able to strap nicely. Without strapping, it's very difficult to find out the intersphincteric plane. Strapping is the very key role. Forceps.
That is
This is
very
one way is
important to
leading.
separate between the space between the internal and external sphincter, sir.
Yeah. And some difficulty will be there. It is not very easier post lift, but we could able to manage.
If the plane becomes difficult, which side will it be preferable to err? On the anal side or taking a few external sphincter fibers if your plane is not very clear in a redo or a bad sepsis, sir?
Always my recommendation is go to the anal side.
Anal side.
Anal side, and that is also, suppose you are very deep, then if you are initially starting, when you are going start the dissection, go to the anal side, and if you are deep around last case like very deep, then go to the muscle side. If you deep, if you go to the anal side, you injure the mucosa very deep, then that will be very making a disease more worst. You are worsening the disease. So the starting dissection, go to the anal side, and then if you are going deep, then go to the muscle side.
Okay.
Section which மறைக்காத பெருசா வெச்சு.
I am not getting the video.
You are not getting video?
OT videos, sir. OT videos.
OT videos.
From the beginning, huh?
No,
Just now.
Okay.
Just now that only our video is seen.
Yes.
Got it.
Bipolar இங்க பாரு, அங்க இங்க வந்து திரும்பி அத வாங்க சொல்லு. பைபோலர் இன்க்ரீஸ் பண்ணி வைக்க சொன்னேன், ப்ரோப் மாத்த சொன்னேன். Even small bleeder you can proceed, but I want to show the clear field. Now can you see this track?
Yes, sir.
Yeah, thick and mature.
Yeah, it is a wide and thick track. So I'm going to hook the track now with the right angle. See this right angle, I'm making it. I'm not able to pierce it. So that means some resistance is there. So if resistance is there, that is the track. Don't try to introduce forcefully your right angle. that means you will go through the track. Okay. So again, I'm shifting my retractor here. I am deepening the space. The fibrosis on the muscle fibrosis, right angle will go easily. If the track is there, it won't. It is very difficult to know the bleeding again. Yeah. டேய், நீ என்னடா செல்ஃபே பண்ண மாட்டேங்கிற, அப்படியே நின்று so it is a deep, it is a small, big bleeder is there. It is on the since the patient is posterior prone. Suck பண்ணு sister. This is the posterior wall. This is on the anterior wall is there, and sometimes no that much deep we cannot go. We have to apply blindly. நல்லா suck பண்ணிக்கோ. ரெண்டு பக்கம் பண்ணு. So again I have to, I'm taking this thing, loose பண்ணிக்க கொஞ்சம். Okay, now it is entering easily. நல்லா retract பண்ணு. So again that coagulated vessel got injured. Now it's a very, no, it's not accessible. So I can access this vessel after the this one, no, ligation of the division of the tract. அப்படியே செய்யும். இது என்ன இவ்வளோ சின்னதாக இருக்கு, பழசையே போடும். After started using this loop, I'm very happy. எடுத்துரு கொஞ்சம் எடுத்துரு. ஓகே, இப்போ போட்டு லூப் போட்டு போட்டு போட்டு. This is the, you can make a ruder's knot. This is the gem loop knot. No, sisters making is gem loop knot. For a Vicryl, gem loop knot is better than the ruder's knot. That is designed for catgut, not for any other suture. Yeah. See, it is a superficial track compared with the last case. So I ligated.
But the internal opening will be high up, no?
Yeah, it is ligated. Suck பண்ணு, இது கான்சென்ட்ரேட் பண்ணாத, சக்ஷன்ல மட்டும் ப்ளீடிங் இருக்க கூடாது.
So we'll have.
சக் பண்ண மட்டும் பாரு, இது நல்லா. So now I'm injecting hydrogen peroxide.
Nothing is coming, sir.
Sorry, it is not. It's not coming to anywhere.
Yes.
Yeah. Initially it went on both. I tightened again. So I'm going to divide the track. Then I'll control the bleeding.
Yes, sir.
அதை எடுக்க சொன்னேன் சார், இதை மட்டும் பாருங்க கேட்க. இதை அடைச்சிச்சு பெரிய செக்ஷன். சீக்கிரம் பண்ண ஃபாஸ்ட். இது சக்ஷன் வரல, சக்ஷன் வரல பாரு சிஸ்டர். யாரா மிஸ்ட் இருக்கிறாங்களா பாரு. புரு சிஸ்டர். இதை பிடிச்சிக்க. So now I'm dividing the track.
Yes, sir.
Can you see this unhealthy granulation tissue?
Yes, sir. Yes, sir.
So I'm dividing on either side. So you can see this, unhealthy granule. That is the opening. There is a big opening is there, and you have to see the anterior wall of the track also. So it is a very much wide or some cavity must be there. நல்லா இருக்கு இது பண்றா. See, now I'm dividing the anterior
Yes.
wall. Because of the bleeder, no, we couldn't retract much. So you have to see the circumferential track wall. Then only your ligation will be
Yes.
completed. Can you see the circumferential
Complete
wall?
circumference has been divided.
Yeah, complete circumferential. You have to see. Otherwise, no, you are going through the track. That is a partially open bipolar. Gas fixture forceps என்கிட்ட கொடு. எடுத்துரு. So that is the spotter is there. I am going to see where it is coming. Suction is coming. Suction.
அந்த கண்ட்ரோல் செக்ஷனை ரெடி பண்ணி பார்க்கலாம். இன்ஜெக்ட் பண்ணி அதை விட்டுட்டு
Suck பண்ணு, suck பண்ணு.
இந்த இங்கே இருக்கும். இந்த ஓரம்
இங்க.
மேலே கையை வச்சிருக்காங்க.
ஓகே. கொஞ்சம் வருது. சக் பண்ணு, சக் பண்ணு.
மா 50 கொஞ்சம் எனக்கு
சக் பண்ணு, சக்.
Have you tried the Lone Star retractor here? Means whenever deep kind of this thing, I find Lone Star a
Okay.
little bit useful.
Useful. Okay, okay.
Okay.
I didn't try so far. Yeah. சக் பண்ணீங்கன்னா வராது. தண்ணியில் வைக்கக்கூடாது. ஓகே. ஹைட்ரஜன் பெராக்சைடு கொடுங்க.
Yeah. Definitely for rectovaginal, it's very useful. So similarly, I think when it is a deep track, maybe it's useful. Yes, sir.
Deep track means that traction becomes very difficult. So
In prone, you are telling.
all even
Lone Star in prone.
prone.
Okay. So again, I'm here also same because the source, main source is being ligated, already ligated. So we have to take care of the external thing. Probe good. Here it is communicating like this. Whether it is going to that place, because I introduced this, so it's going here deep only. Probe is coming this side. It is here. It is not. It is no. There is no connection here.
Hydrogen peroxide came, no? Both from every.
Yeah, hydrogen peroxide came when I injected. It has a superficial connection here. It is not deep. It's already when I divide this track, this connection got divided. So now I'm not going deep. Just I divide this. So I'm trying to cure it of some portion. It is just below the skin. There is a cavity. I think you can able to appreciate the unhealthy granulation. This is coming.
Yeah.
The
cavity is
Probably the
here.
subcutaneous
This is the
cavity was going towards that intestine opening side.
Yeah, it is subcutaneous cavity. Yeah, just below the skin. Very section. Because of this cavity abscess, no, the bleeding is more. And this case, I couldn't take the entire track because the cavity is there. Artery forceps. Once you pus is coming out, when you are pressing surrounding, then you see expect some cavity. Can you see this artery forceps is
Yes.
coming this side, but it is not like a big opening. Maybe some connection here, but if it is a deeper one or it's going above, like a suprasphincteric or this one, then you can keep a drain. Now it's no need.
You will leave that intersphincteric bit of the tract which is going up to the internal opening like this itself.
Here I am leaving the track, intersphincteric
Slightly
track.
longish.
What is your
Sir,
question, Vinay?
the
Yeah,
distal
this
one
is
to the
this is
ligation
the
looks slightly longer. So he's
Okay.
asking if you're going to leave that or excise a bit of
yeah,
that.
from the internal
Yeah,
opening till where you
yeah.
ligated.
This is. I'm just coagulating that granulation portion. I'm just leaving. I'm not doing anything for this.
Some audio.
So that's why when you are ligating it, you have to go close to the internal
Ah,
sphincter.
so in this case, a little bit long tract is there, no?
Yeah, it looks like a little bit long. So I'm going to take a transfacial suture. Then after transfacial, if it is so long, then I can excise. But if you ask me, I don't
Okay.
excise at all. If excise means you will make your suture loose.
Once that
That making
disconnected
your
and
suture.
transfixed, that more than enough, sir. The principle of the lift has been served very well, sir.
Yeah. Can you lose it? It is kind
Box.
of fasting kind of suture.
So you try to put like a box stitch, sir.
Yeah, box stitch. Your success of surgeries depends on this two stitch, the first and
That's true.
second. Externally curating, taking the track, no, anything is there, we can just curate is enough. No need to take the track for all cases. And if it is cavity is there, then you have to take care of the cavity. Otherwise, no, it will be healed nicely. Any bleeding is there, just coagulate, then come out. And next case ready, suction good, suction. Gas piece, forceps good. Gas piece, so cavity means some hose will be there.
That is fine. That will stop.
Yeah. Okay. Okay. Give me wash. And I can say around 50 to 60% of the case like this, superficial track, and easy to identify the track, even in anterior fistula. And you will expect around 20 to 30% like a previous case, deep one. Even the investigations, they tell investigation wide it will be superficial, but it is a deeper one. And most of the time the MRI doesn't tell the correct position of the track. Instead of 11 7 o'clock, they might tell 5 o'clock because of the position done by a technician. So no, it will be misguided to the radiologist. So that's why we cannot rely on MRI. Maybe if you are able to read it, then you can read the MRI. And my thing is transrectal. If you train a person, and then it will be your PR rectal digital rectal examination and transrectal ultrasound is matching, then that is good enough. No need for MRI.
Many
plaster.
time radiologists also struggle to read the MRI, sir.
Yeah, most of the radiologists doesn't know read how to make it
It's always
MRI.
difficult for them to what actually to read and what actually to interpret.
Yeah. What I saw a very beautiful lecture, Samrat, in your symbiosis. Your radiologist very
Yes,
nicely explained, and he told that you sit with your radiologist, and then you are educating your radiologist. That is a very
yes.
important thing. Even in the இங்க புடிச்சுக்க, இங்க புடி, இங்க
Uh,
கை வை. இல்ல
recently
கொஞ்சம்
they
எக்ஸசைஸ்
had
பண்ணு,
a one.
சின்னது போட்டு. You have to educate because they're seeing only the black and white image. They're not seeing the real image, and so we have to educate our radiologists what are
Yeah,
the things
that
we
is
want.
most important, sir, because they also don't know
Yeah.
what report giving
What
them helping. They also don't
is
know. If we tell them
நல்ல
this is
separate
what we want, they will be. Nowadays, they have started putting the fistula patterns and mappings and nice images, which is also helping, sir.
what Samrat? I couldn't நான்
Many
miss
a
it.
time they also don't know what actually surgeon want. As because of that, it is a
Yes,
struggle
yes.
was happening. And nowadays,
Yeah,
there is a two center maximum. I do fistulogram, sir, and both center radiologists I sit along with them and ask them this is what I have done. And because of that, nowadays they started giving a mapping and patterns on the reporting, which also makes happy for
yes,
us to understand and do this.
yes. So that is that is initially our work is not doing surgery
Yeah,
alone. We have to
definitely
educate them.
true.
Not only see what I do, if I suppose if I do gastrectomy and Srikanth is giving it is a no pancreatic infiltration, no mesocolon infiltration, then I could see the transverse mesocolon infiltration. I could not proceed. So what I did, I selected a normal case, regular case, early case, and then how it looks like a pancreas, and so this one anterior transverse mesocolon, and then I showed a video, and then I showed this case, inoperable case. Then I asked the Srigan to see the normal case first. See the mesocolon how it is appearing. Now you see the transverse mesocolon this way. Then he could able to feel the
Yes, sir.
difference. So like that, each and every
Sir,
case, if you show the video
yes,
to
sir.
the radiologist, then they will be they
The
will
trust
understand better.
report, what you get, sir, this kind of report nowhere, no one can give, sir. He gives so much of precision on the fistula, which is very good thing, sir.
Yeah, because no, otherwise, if we may, because I could see
Yeah,
the external opening, I could feel the internal opening, most of the cases, but I cannot
yes, sir.
feel the track, intersphinctic track, no, per a digital examination. So if it track is not matured, and there's any abscess within the track, then my surgery, definitely the
Yes, sir.
failure rate is high. So to avoid this, I look for these two things. So all these hemorrhoids, any other thing is there, no, I don't touch actually. Some of the patient also ask whether it's possible to hemorrhoidectomy also. But all those procedure, no, hemorrhoid, Milligan Morgan are painful procedure. And maybe you can combine some laser, but that also I not tried. I just clear the, which is more, no, cumbersome or difficult to the patient, that
Yes,
to
sir.
be done first. So come for fistula means we'll do fistula alone. He is working somewhere in Maharashtra, Tamil Nadu patient working in Maharashtra, and this patient is telling so much work is doing. So I don't know how he is going to manage post-operatively. But anyway, it's only the superficial fistula, so it can be easily manageable. Yeah. Usually only two stitch used to put, because of the bleeding. I extended the incision. Second. I'll put one more.
When you do deeper dissections in deeper fistula, sir, do you close the deep intersphincteric space in one layer, approximating the sphincter, and then close the skin, or what will you say for deeper fistulas for closure of the intersphincteric wound, sir?
Yes. So what I did when I beginning cases, I started doing intersphincteric closure with the Vicryl, and I used to ask the patient to stay in the ward or come to daily for my OPD to see the any intersphincteric abscess developed or not. But it is no abscess developed, and nowadays I stopped doing this intersphincteric closure. Now can you see this is the wound closer, and would remain leave it. I'm not closing, even in the deeper cases, I'm not closing the intersphincter plane. The muscle I'm not closing, only the skin.
Okay. So if you are not closing the intersphincteric space, is there a reason where you will drain them, sir? If it is a deep abscess, do you put a small tube for 1 or 2 days? Any,
No, if it is any suspected cavity is there, through the external opening, I keep the drain tip in the intersphincteric plane for wash. If there is no cavity, no abscess, and then it's no need for close the intersphincteric
okay, sir.
space. Here the cavity is here, not towards the 12 o'clock. So I'm trying to suture above. Cut பண்ணு நல்லா வரல. இங்க நடுவுல cut. Yes, yes, yes. I'm closing above. So I'm going to leave that part close to the 12 o'clock. விட்டு லிஃப்ட் பண்ணாரு. டைம் உருண்டே வந்துருச்சு. External opening side, no, if you are exercise the external opening, then you can suture. No, otherwise that opening will take long time to heal. And then we are not discussing about how to manage the fistula patient. Usually, in my experience is uh, gallbladder patient, no, well, as patient symptomatic gallbladder or hernia patient, even a very difficult complex hernia also, only 5 minutes or 10 minutes I'll spend with them. But a fistula patient, they used to ask so many questions, particularly recurrent fistula, very difficult to manage. How is
It's
your experience? Even I'm not spending much time for a gastrectomy patient
True,
also.
sir.
I'm not spending much time for a gastric CS stomach patient, but fistula patient taking more of my time in
That is
OPD.
true, sir. Recurrent fistulas, patients on this patient and the surgeon side is the biggest challenge.
Yeah,
Yes.
it's very difficult, sir. Prior operated patient, if come to your OPD, he will be very knowledgeable. He knows about that incontinence, recurrence. He will be talking in that fashion. So it will be very challenging. But I personally feel, sir, these patients are very much loyal. Once they get cured, na, sir, then
Yeah.
people will be
They
like,
they treat you like a god actually.
yeah, that's
Yeah,
absolutely true, sir.
yeah. And they used to send many patients, and some of the one patient, no, long time back, I operated one from village, lady patient, fistula. Then another lady came within a month, and then that lady told about the previous operated patient name. Then both of them are the farms nearby. They're sharing their no this one, because I thought the fistula thing they don't share to others, but it is happening.
Yeah,
So now you can see very small wound I left there. So
yes,
this is the collection here. So I can put a tube and then wash. So this wound will be healed fast.
yes.
It's not packing, just introducing it minimum. So it's no catheter, nothing. And I'll ask the patient, feed the patient within 2-3 hours. Next day discharge. Okay. I'll go for another case. Thank you.
Yes,
Yeah.
Oh,
Meanwhile, you discuss something. Another
yes.
3 minutes, I will be ready. Yeah.
ஒரு வீடியோ டெக்னிக்
Hello. Uh, yeah, I'm
Yes,
going
sir.
to show. Yeah, I'm going to show the one small video, 3 minutes video. Since another case is getting ready. This is a transrectal ultrasound report. The patient had a root of the scrotal perineal collection with internal opening at 1 o'clock. This is the antral fistula in male with the root of scrotum with the abscess. So this is the abscess cavity, and it is opening at 1 o'clock. And the patient is in prone. You can see I expose the scrotum nicely in such a way. Otherwise, initially what I do, I just close the ligate track, and then I turn the patient to the lithotomy to clean this abscess cavity and then excise the track. So nowadays with the prone only we can able to expose like this. It is not a jackknife. The prone with the pillow in the hip and then tie so that we can able to expose this. So now already the incision is made. So that is the internal opening. The incision is already made. I enter the intersphincteric plane. Uh, So can you see I'm just trying to identify the track. I'm going between the on either side of the track. So this is the track. That is the track. Its fibrous track is seen nicely, and then I'm hook the track. This is little deep. It's not a very superficial, deep only. So I hook the track, and then the thread is going to be same technique. I'm not changing the technique, and I'm ligating. You can see it's a ligation very close to the internal sphincter, and then some sphincter fibers is also included. So again I'm injecting now, so there is no hydrogen peroxide is coming on the anal side. So that means it is a tract is being ligated. So I divide the tract, I tighten it again. So that is very important. So now again I'm injecting the hydrogen peroxide. You can see it's coming through the divided end. So this abscess cavity to be excised, and then if it is a bigger cavity, then I used to keep a drain. Anywhere, no, the cavity is bigger. You can in the gluteal region, squarectal, and here the root of scrotal abscess. So I excise the skin and then subcutaneous. Now you can see a lot of unhealthy granulation is coming. Such a good big cavity. Uh, so this is the hydrogen peroxide with the betadine solution combined, to clean that cavity. So I make a nick and then I keep a drain. Usually 14 size drain or any 12 size is advisable. Yeah, I thought I want only minimal drain. So I keep some of the cases, initially with the feeding tube that is slip, that is usually within a day it will come out. It won't, even if you suture nicely, it will come out. So always if you want to keep a drain, 14 size is ideal. And if you give a wash, you can use the Nipro syringe so that it will accommodate the mouth nicely, so water leak will not be there. And even here also you can see I'm closing the external opening wound. You can see like this, only the water to come out, so that much small amount you leave it, otherwise you close all the wound. So that is the main advantage. There is no wound left behind here like a fistulotomy or fistulectomy. So patient, post-operative management is very easier. since the case is getting ready, so I'm showing another video. Straight away the surgery is being started. Again, I don't know, it's around 12 o'clock only, 1 o'clock basically. And see, it is a 1 o'clock track. It is a little superficial track. So can you see this track? No, very nicely seen. Some patients, it will
Yes.
be like this, and you can now we can see the cyst is helping to push the this one thread to close to the internal sphincter. Now I'm injecting; it is not coming to the internal opening, so I'm dividing the track. Usually, the track traveling through the external sphincter to be excised. I think I'm going to do this case. The skin around the external opening is not healthy, so you have to 1 or 2 mm skin you can take it, that is better. All cases, no, I told you, no, 1 centimeter track is traveling through the subcutaneous 1 centimeter, then it will go towards the point of thing. So this here it's a very small track, I excised completely. Still some of the track might be there, I'm seeing inside. So this is the divided end of the track. I'm taking a posting kind of thing along with the internal sphincter. So I ligated. The patient had another track might be, you can see another opening at 5 o'clock. So this is the complex fistula, comes under complex category. It's a multiple track. So again, I'm opening around 6 o'clock to 4 o'clock or 5 o'clock. I'm dissecting the intersphincteric plane. Again, you can see it is a superficial track only. So again, it's a superficial track, and you can see the track. Some patients, no, you will get like this multiple fistula in a single patient, and any number of fistula. I could multiple opening. I have done many multiple fistula. 3 track I excised. One patient got a 3 track. I excised 3 track. This patient got a 2 track, so that is excised. That is a small opening I cauterized. That is the opening in the track. Again, same thing, posting stitch, or what you told, it's a box stitch. It's around the divided end of the internal track, and again I'm excising the external opening. So both of know the healing will be. Can you see the track? No, it is very going deep. The principle is same. You have to stretch the buttocks nicely in a prone approach, a prone position, and then go into the intersphincteric plane. Find out the track, ligate the track close to the internal sphincter, divide the track, and excise or curate the remaining track. And if you are excising the track traveling through the external sphincter, then you have to suture the defect in the external sphincter. So this is the basic principles of lip surgery. Ready, Alka? இந்த person என்ன relate பண்றாங்க. So this is one of the another interesting case. This patient had a ano-vaginal fistula, and you can see patient had a ano-vaginal fistula. You can see how I manage. Samrat has experience of doing this with the flap. I was on some cases with the flap. This is, you can see it is coming here. It's coming here. It's a very clean case, and most of the time, post episiotomy, young female post episiotomy, it will be like this. But my first surgery will be, I don't do this, labia majora flap. I do this lift procedure. I could, if a track is there in the intersphincteric plane, you can see it is connecting the post-vaginal wall and the anterior rectal thing. So I find out the track, I ligate. And most of the time it will be around 2 or 2.5 centimeter track only. This is one of the minimally invasive way of management of this anovaginal fistula. And if it is fails, then I go for other flap procedures. And this patient complaint is, see now again I'm now injecting. You can see it is not coming through the vagina.
Yes.
Major complaints is gas passing through the vagina, and then liquid stool passing through the vagina. This will be the major complaint of this kind of patient. And today also, yesterday, sorry, last OT day, Friday also, I have done one case like this. Now you can see I'm injecting from vagina, it is coming through the intersphincteric space. So now I'm taking, no, from the post-vaginal wall, I take out the extra opening, and then I'm going to take out the tract. How much tract is there? I'll take it out, and then I close the vaginal wall. The healing is so nice, and most of the patient is benefited with this, minimally invasive method of lifted procedure.
Yes.
See, that is the sphincter, no? The sphincter defect in the sphincter, I'm making it. The tract traveling through the external sphincter, I'm dividing. I'm not dividing the sphincter. I'm just coring out the tract. So that will have some defect in the sphincter. I'm just divided it. This is the passing stitch around the divided end of the proximal tract. That is close to the internal sphincter. I'm dividing the tract. So both place it's closed, and then finally I'm releasing the strapping, and I started closing the vaginal first. This is, you can see the edge of the vagina, so it will be healing is good. Source is removed basically, so that the healing is good. Even you can apply lift for anavaginal fistula also. In case of this superficial anavaginal fistula, all anavaginal fistulas come to me. I used to do this one first. If it is fails, then I go for other procedures.
Okay.
Okay. I'll take another 2 minutes gap. I'll come with the other case. Okay.
Okay, sir.
Thank
Okay.
you. Thank you. Thank you.
Pashupati, can you show that sir is doing very important step of the procedure? Can you show that nicely? Yes. Yeah. Yes. 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 Yes.
Hello, Samrat.
Yes, sir.
Yeah, now I switch off the OT light. Are you seeing brightly?
Yes, sir. Now it is very much clear vision, sir.
Clear, okay. The patient is in prone.
Yes, sir.
You can see if it is a prone, ಇದರಲ್ಲಿ come.
Sir, another camera is showing, sir, that vision is not coming, sir. Prone, your vision is not coming. Distant camera.
Yeah, different camera comes 1 minute. Yeah, Pashupati Mahatma.
Yes, sir. Now it is okay, sir.
Now
it
you
is
can
okay,
see one pillow in the chest, another this
Yes,
type
sir.
of soft hump, it is in the hip region, so that no free movement of the abdomen should be there. That is second
Yes,
thing.
sir.
Third, you can see the gel support for the
Yes, sir.
knee, and then for a this one ankle, and then
Yes.
for a fingertip also.
Yes,
So
sir.
all protection should be there in the supine and the prone approach, and then come here. இங்க வா, இந்த பக்கம், இங்க நில்லு. The strapping is considered very important one,
Yes.
and no, you can see now the all around, it is very much exposed, the perianal region. First thing I used to strap this side, it was
Yes,
connected
sir.
to the patient's, the OT table, and then again this one, and then if it is an anterior fistula, then thigh should be retracted. Here, this patient doesn't have any hole, only small hole very close to the anal verge, and it's a horseshoe abscess, basically horseshoe abscess. From 4 o'clock
Okay.
to 8 o'clock, abscess cavity is there, and then it's draining pus through the 6 o'clock internal opening, and then Cori external another opening at 8 o'clock, MRI wise.
Okay.
Because this case
Okay.
pus is not good, because my perrectal examination I couldn't see much. That's why I sent for MRI. There is no
Yes, sir.
external opening. I could see small opening here with the pus.
Yes.
Light கூட இன்னும் கொஞ்சம் clear ஆ தெரியும். And
Yes.
that's why MRI is done. Iris கம்மி பண்ணிக்க, நல்லா
Yes.
focus பண்ணிட்டு.
Able to appreciate, sir.
Yeah, the pus is coming out here.
Yes.
And another thing, any opening, external opening very close to the anal verge, it will be difficult to operate.
Yes,
Most
sir.
of the time it will go very depth, direct vertically down, and then
Yes.
curve, and then is opening at 6 o'clock or 12 o'clock, mostly 6
Yes.
o'clock. So
Yes.
that is very difficult to operate. If the ultrasound or any MRI gives 5 to 6 centimeter length of track, and then if you see the external opening is very close to the anal verge, that will be the most difficult case. Okay. And now you can see this trapping is like this. Entire perianal and the perineal, lower part of the perineal region is exposed, and then I'm going to paint, and then I'm going to start the surgery.
Yeah.
Okay, 2 minutes. Okay.
That penis also made ventral, sir, anatomical.
What, Samrat?
Penis we have taken anatomical position.
Yeah. When you go with prone, you have to take out the penis. It should not be compressed,
Yeah.
because since I keep this this one, hip.
Yes, sir.
Yeah, thinking then this penis will not be compressed.
Yes, sir. Yes,
Okay,
sir.
thanks.
Nice, sir.
full. आदित्य पवार हां त्याचा फोन होता उलटी होती वाटतं.
மைக்கு சரி ஹலோ கொடு ஜெல்லி. So I'm starting the another case. Just see the MRI report. So the MRI report. It's one of the very complex fistula. ஸ்லைடில் இருக்கா? இருக்குல்ல, ஓகே ஓகே. அது ஒவ்வொரு ஸ்லைடாக மாற்றிடு அப்படி. ஃபர்ஸ்ட்லேருந்து வா. இட்ஸ் 75-year-old male. Perianal abscess managed conservatively 3 months ago. Next. Yeah, the rectal examination, I could see external opening. It's a small, very small opening at the level of anal wedge, not 2 centimeter away, level of anal wedge. And then I could see some induration, must be maybe internal opening 4 centimeters from anal wedge. And this is the transrectal findings. MRI put. So this is the MRI findings, and it has a deep abscess, horso abscess around 4 to 8 o'clock, and is connecting to the 6 o'clock opening and 8 o'clock opening. 2 opening is there. The 6 o'clock opening is around 3 to 4 centimeter. According to MRI, 8 o'clock opening is 5 centimeter depth. So I don't know whether I'm able to occlude both the opening, and you can see there is no external opening. This is the one. This is the one art refers to. So this is the one no external opening. No, we could able to tell, but it is also not classical. No, it is going inside. Put a hydrogen peroxide. But there is no external opening. But all abscess is deep Hartshorne abscess with the internal opening. Basically, it is abscess with the internal opening. So I'm not able to do anything. According to the MRI and the truss, the external opening is at 6 o'clock position. Nalla down. 6 o'clock position, and very deep, very deep. I'm going in patient is in prone, so this is the 6 o'clock position. But I'm going to enter the intersphincteric plate at 6 o'clock. இங்க கை வை சிஸ்டர், நல்லா அழுத்துற. So this is the inter no mucocutaneous junction. So I'm going here. This opening is at the mucocutaneous junction. I'm not going there. I'm going above. நீ இதை அழுத்திக்க sister. And here finding out the intersphincteric plane is a challenging one.
Yes, sir.
விசர் நல்லா இருக்கா பசுபதி? சரி. As much as possible close to the internal sphincter I am going. Getting intersphincteric plane 12 o'clock is much easier than the 6 o'clock. I'm extending the incision because now I want to go deep. According to the investigations, it is a very deeper internal opening. Bipolar. My cartridge setting, monopolar cartridge setting is 25.
Okay, sir.
20 or 25 is fine. இங்க மட்டும் போடு. Okay. தூக்காத மறக்க. So good light, good retraction, and good team. Like success. Lab usually we used to tell good vision, good team, good camera surgeon, like that. Here also, here because no very minimal incision, no minimal exposure we are operating. So everyone should have that knowledge, so that now we can able to do better. So now I could see some fibrous structure here, but even though it is very superficial, but it is a good fibrous feeling is there. I just make a little bit extra opening.
Yes.
Can you see this internal and external? I'm retracting.
Yes, sir. Yes, sir. It is
go in intersphincteric. This is the internal sphincter.
Yeah, it is very much appreciable, sir.
Okay, Samrat. And the Apple company, they introduced one a device that is called Apple Vision Pro.
Yes, sir.
That is one of the glass, like computer, basically computer attached to the glass. You can just fix it to your face, and you can see all the it's more than 3D view. You can able to see. It is like a immersive technology. the kind, no, you can, if you see some, if you watch some match, you are sitting in the ground or standing in the ground, you are watching the match like feel will be there.
Okay.
That is called immersive technology. A lot of application, healthcare application has come. They need நல்லா retract பண்றாங்க. இங்க போடுறா நான் அப்படி இருந்து சொல்லிட்டு. And what I did, I just used the Apple Vision Pro as the monitor. I did a laparoscopic surgery, and I did a lip surgery also using the Apple Vision Pro,
Okay,
so
sir.
that I can record in immersive technology, immersive video. During my lip surgery, the immersive video can be recorded, and if it is watched by the Apple Vision Pro, is like different feel. It's more than the normal vision. And maybe if I recorded it, and maybe in future, many of it can come to the phone also. The immersive technology will come to the phone or with this type of VR devices, so that the future the surgeon can get experience the lip surgery with the immersive view. So like that, I started recording the lip surgery with immersive technology using Apple VR, and if possible today I'll show that Apple VR
Wonderful, sir.
live surgery with Apple VR. Okay. The skin வந்துருச்சுடா. இங்க பாரு ஸ்கின் இங்க அதை விட்டுறா இங்க வரணும்டா. So here the fibrous feeling is there. So what I did, I am separating this fibrous structure from the external sphincter.
Yes, sir.
அதுக்கு தான் ப்ளீடிங் இருக்கு, நீ மறைச்சு வச்சிருக்க ப்ளீடிங். ஓகே. எங்க இருக்கு? ஓகே. ஃப்ரெஷ்ஷாக பண்ணுறா ஏன்டா? Okay. Last case, not the last case, first case, I told to my Naveen to change the patient to prone, lithotomy,
Yes,
and then examine the post-vaginal wall. That's
Yes.
why this case, getting delayed to start.
Okay, sir.
He couldn't say anything. Everything is fine.
Okay, sir. Okay, sir. That's great, sir. That
ஏதாவது சூச்சர் போட்டியா? No suture. I told them if you feel any hole or anything, they put a suture, but he didn't suture anything. He told me that it is everything is fine.
okay, sir.
So I'm trying to go deep in the intersphincteric plane, and here is the fibrous structure, very wide thing. Since it is a horseshoe abscess, it will be wide only, and I'm trying to go behind. Yeah, it's going freely. I may go through the cavity, I don't know, but anyway, even if I go through the cavity, if I able to நல்லா retract பண்ண மாட்டேங்க.
Yes, yes.
If I able to divide the proximal track, then it will be success. It's very wide. Most of the time it will slip if it is too wide. So after ligature, I used to take a transfixation suture. Sister, can you see some unhealthy granulation tissue is coming here, this point? Internal sphincter மட்டும் divide, separate. So again same technique. The principle is same. I'm not changing the principle in any of cases, but only thing it's a very deep track or superficial track depends on the case. And most of the time the wide track, no, that your knot will get some, including the sphincter fiber, you will not get loose. See, I tied it very tight nicely. When I divide, if I could able to see the granulation tissue or opening, then it is a track. Can you see this granulation tissue?
Yes,
Hole?
sir. Yes.
Yeah. So that is the hole. But anyway, track is being 6 o'clock is being ligated. Can you see this? Yeah, that is the hole. But the induration fibrosis is more. Can you see this all around now?
Yeah, granulation tissue is there.
Yeah. பிடிச்சிக்க எடுத்துருது. So I tied nicely. Now you can see non to the force system. Here the mistake had happened. You can see the mucosa got opened.
Yes.
Samrat? Yeah.
Yes, sir. Yes, sir.
So now, if I do your technique is better. The sphincter can be excised along with the track.
Because initially technically was not good and many a time mucosa ruptured. So then started.
Yeah, that's why I went on the muscle side. I told you, no, Balu question. Initially you go close to internal sphincter, and when you go deep, then go away from the internal sphincter to avoid this condition. So I'm exercising the track traveling through the external sphincter.
Nice thick track, sir. Mature, nice track.
Yeah, thick track. Yeah.
It's going towards the ligament.
Can you see this bigger cavity is getting open? Track is getting open. That is not track. That is a cavity. That is abscess. No, horseshoe abscess.
Yes, sir.
See, that is analytic granulation tissue is there. I'm going to exercise the entire track. Okay. எனக்கு forceps நல்ல traction. கேமரா விஷன் நல்லா இருக்கா பார்த்துட்டு தெரியலன்னா கேளுங்க. So I'm separating the track from the external sphincter. So each fistula you are seeing, no, it's a different way it is presenting.
Yeah, it's absolutely true.
So that's why there is no uniform way we cannot do. So I'm following the principles of lift, but the excision and curating is different, you know, between the cases.
So the other thing, the other thing I wanted to ask is that whenever you are doing redo lift, in the case where there is a recurrence, in those cases, do you exercise the cryptoglandular complex?
Redo also rarely I'm doing. I'm not exercising in all cases.
Okay, sir.
Maybe I can follow that, maybe, you know, prevent the recurrence. I don't know, but redo lift also I'm not exercising the cryptoglandular complex. So that is a cavity like thing. Bipolar forceps. So the opening become bigger now. So now the internal sphincter is there. There is a ligated, but it is a சப்பரி செக்ஷன் கூட ஏன் இப்படி பண்றேன்? ரெண்டு பேர் பண்ணாங்க, ஒருத்தர் பண்ணுங்க, அப்பதான் கரெக்டா வரும். So now I have to divide this and then suture like this. So what is your, because if I suture you can see no, it is a very deep.
Yes, sir.
Saline.
If we divide internal sphincter,
yeah, we can divide. No, we cannot. Nothing. Yes, Samrat, what you are telling?
sir, if we divide that internal, if we can suture out, or we can divide internal sphincter and mucosa, may not be a problem, sir.
Yeah. So I'm going to do that now.
Yes.
If the mucosa is not open, then that is a great thing. But
Yes.
it's open here,
Yes,
because
sir.
of the fibrosis maybe, or it's a deeper tract. Now you can see.
Yes.
I'm dividing the muscle.
Yes, sir. Yes, sir.
So this is a divided proximal tract, basically.
Yes.
So along with the muscle, bit of muscle I excised.
Yes, sir.
Yes. So this is your modification. I think you
Yes.
are doing all cases like this.
Yes, sir. Yes, sir.
Okay. Okay.
நீ லாகின் பண்ணலாம், அதான் அந்த இதை அனுப்பிச்சு அந்த சம்மதி மட்டும் நாளைக்கு போற அடிச்சுட்டு.
So another thing, MRI shows 8 o'clock. I'm not seeing anything. Even preoperatively also, I couldn't see anything on 8 o'clock. So I'm not doing for 8 o'clock tract. Now only 6 o'clock I have done it. Saline.
Yes.
Very section. Saline. So what I do, I just suture this like this.
Yes, sir.
Yeah, to the previous mucosa, I just suture like this, so that it will be help for a little bit fast closer.
Yes, sir.
Yeah, nalla retract. Gas piece வச்சு தொட. இல்லடா ரிட்ராக்ஷன் பத்தாது, நீ ரிட்ராக்ஷன் மட்டும் பண்ணு. இப்படி பச்சு அவ்வளவுதான்.
Any prior history of
Voice is breaking, Samrat. Any
prior history,
past history of what?
Surgery, sir.
Yeah, it's only IND done. There is no fistulectomy or fistulotomy, only IND.
Okay, sir. Okay.
Sir, in your practice, in what percentage of patients you encounter the situation where the internal opening, inadvertently the anal mucosa opens up, and how do you rescue the procedure, sir?
Yeah, that is, if you are expecting this carefully, then we will avoid this. But some cases the intersphincteric abscess is there, then this is the chance of opening the mucosa is high. This case there is a cavity in the intersphincteric plane. When I try to excise the cavity, then mucosa got opened.
No, that's what, sir. In experience hands like yours, who has the biggest number? So about 1 or 2%, sir. How many percent do you think you will have this situation, sir?
Percentage wise, I cannot
Right,
tell.
sir. So very
Maybe
small number.
very minimal. Maybe 1 or 2 you can make it. Yeah.
Okay, sir. If there is a cavity, so do you always mark supplies and leave,
Yeah,
sir,
yeah.
or you
I
weaken, sir?
don't recommend. Yeah, sometimes 6 o'clock, maybe around 2 centimeter, the dentate line level opening will be there, and then the patient will have a intersphincteric abscess. Those cases, I just make a patient a lithotomy. In lithotomy, I just make a excise. I try to excise the opening, and then that time I'll enter the cavity. uh, then I put a drain come out. It's like that. So it is
Okay, so
very,
you do a
I don't do
intraanal
lift in
hysterotomy
those.
sort of thing. Okay, sir.
Yeah, internal fistulatum, I can say like that. It is not lift will not be attempted in that case. Clean வச்சுக்க ஃபீல்டு எங்கே போயிட்டு இப்படி here skin is going down, and we'll see post-operatively how it's healing. Ah, retract பண்றாரு. கட் பண்ணு. Okay. 2:30. I think I can show another case also. Ready and கேளுங்க. That is also another difficult case.
Yes.
There is a internal abscess with internal opening. There is no external opening, it seems. I forget. ஒண்ணுமே யூஸ் இல்லடா நீ பிடிச்சது. So the raw area become a little bit bigger. This case, we have to wait for the healing time. Here the fecal matter will not accumulate any of the cavity. It will come out. So the managing this raw area is easier.
Yes. Sir, for pain relief, anything you
Which one, Samrat?
post-operative pain, any infiltration, anything you give, sir?
Painkiller you are asking?
Yes, sir. For pain relief, any block or infiltration you give, sir?
Samrat, you are
No,
echoing.
I'm not using this. I'm not using Samrat, but if a pudendal block or something is better, and I'm not using anything, just a regular painkiller. That's all. Now this hyaluronic acid with the sensorkine, the combination. I think Balu presented once, I heard.
Yes, sir. Methylene blue we are using routinely, sir. First 2-3 days the pain relief is very good, sir. 3 days the pain relief is very good, sir. With methylene blue we are using, sir.
Methylene blue, you inject, huh?
Sir, 2 ml of methylene blue mixed with 18 ml of sensocaine, perianal and pudendal block, sir. Dr. Roy Patanka's paper, after that everyone has started using it. We also started, sir. We are happy with the results, sir.
Okay. Maybe that we'll try to this patient now today.
Yes.
Okay. So this is the raw area left behind, and I used to ask the patient to take a sitz bath and then clean this area, and then we have to wait for the granulation. Okay. Saline. Sakpat. Thank you. Saline. இன்னொன்று கூட போடலாமா? கூட இன்னொரு போட்டு சூச்சர் இன்னொரு சூச்சர் போட்டு. Remove the plaster. If the 8 o'clock track is really active track, then patient might get some symptom. But clinically, I couldn't feel this 8 o'clock track. So if it is 6 o'clock means entire track and the even the cryptoglandular complex also is removed. This raw area to be healed. Okay. Within 2-3 minutes break, I will join you with the other case.
Okay, sir. Okay, sir.
Thank you, sir.
Thank you.
So, Samrat, in your practice, when do you avoid lift, or what are your alternatives to lift?
Usually I started with lift. I have learned under Dr. Partha sir as we are along with sir. But because of this having recurrent fistula, or if we are having scarred prior surgical area, in those conditions it will be a difficult. Technically, if we are better, you will be performing better lift. Sometimes what happens is it ruptures. So I converted this modification as a lift, where what I do is proximally before doing after hooking, I deliberately divide internal sphincter and mucosa medially, so that the medial hypertension of internal sphincter goes down, and also we are exposing whole cryptoglandular area that we can buzz with a bipolar. So we are having the disadvantageously wound will be created anyhow. It is going to heal by third week, it will heal, and then I will ligate very comfortably on the external sphincter, the track which is going through the external sphincter. It is on my hand, I can see, and I can ligate very nicely. So I like it.
You only divide the internal sphincter, or you excise a portion of the sphincter along with the cryptoglandular complex and the internal opening, like in the PARC procedure? Like, do you excise 5 mm of the mucosa, submucosa, and the internal sphincter, or you just divide it and bus it with bipolar?
No. I take out complete internal opening from the internal sphincter and mucosa, so that the cryptoglandular infected area, anyhow we are doing the procedure for the fistula. In what I do modification, where I divide it internal sphincter, going another one half centimeter above, we can take out the cryptoglandular complex. In fact, doing whatever best procedure, recurrence is known. A little bit added one thought process, which is having some cryptoglandular infection, taking out will help for reducing chance of recurrence.
So now your standard practice is to excise the internal opening and
Yes.
you divide the. You don't just bus it. So it's not that you open the intersphincter space and then you bus it, but you excise the thing. Is that
Yeah,
what you're
I'll
doing?
take out a circumferential internal opening from the internal sphincter. Means it is a vertical division till the internal opening, and then circumferentially I'll take out the internal opening completely from the internal sphincter and mucosa. So it is completely disconnected.
So the internal sphincter is divided, but mucosa, submucosa with the internal opening is excised. Am I right?
Yes, yeah, absolutely true.
Right. So in what situations you avoid lift? So is any pus contraindication for you or very deep tract? So what are the
If
situations you avoid a lift?
Yeah, if it is an acute immature track, lift will be a bit of troublesome. If we are having a high deep track, lift will be troublesome. If we are having a recurrent surgery, perineal surgery has been done in any perspective, lift will be difficult. Technically, if we are having expertise, definitely can do. We have seen Partha sir doing every case lift, he is able to find
That's
out.
what we'll have to discuss about when somebody is starting. What are the situations they like to
I
avoid?
think we need to choose it for the leaf, mature track and well-defined track if we are having, and virgin perineum not previously operated, and not having much pus in the intersphincteric space. That is also very good. In those conditions, success of lift will increase.
Okay. So now in an MRI, what do you ask your radiologist or what do you see to say that the tract is mature?
Actually, the history of the patient also matters. One thing, and second thing, I asked the radiologist what is the width of your fistula tract, which is there in intersphincteric, because the Achilles heel of lip procedure is identification of tract in the intersphincteric space. If intersphincteric tract is wide and mature, then it will be a possibility we may end up with proper lip procedure and we can give good success for the patient.
So if I say that the more brighter the tract is, the more immature it is, and if it is more gray or darker, it is more mature. Is that right? When you
Uh,
see the images?
maybe we can tell. But what happens is the fistula is ongoing process. It's never going to be a one-time fistula and other time abscess. It cannot be. It's ongoing process. It's kind of a female is having menstrual cycle in a month. It's kind of fistula is some amount of fecal matter goes in the tract. In
I
that
agree
time,
with you.
it may having a pus and hyper intense. And other half of the time, when pus has burst and pus has gone, that track will be hyper intense, little bit
True,
intensity will
true.
be low.
See, if there is a collection, it's entirely different. But if you want to say if the tract is mature or not, then you'll have to go by the intensity of the tract. So if it is
That
hyper, then it is more active with a lot of granulation. If it is hypo intense, then probably it is more mature. Of course, we
definitely,
look for collection. Yes.
definitely. But all three cases till now, sir, demonstrated are challenging today.
So, do you use laser? Is laser a part of your armamentarium routinely in your practice with the patients asking for laser? Personally, to confess, my practice does not involve much of laser because, to my mind, laser is useful only for the distal tract ablation. So, a good curating, like in most of the lift or excision of the tract in most of the lift, it does work well. So, in my practice, laser is hardly used in my fistula. It's not that I'm against laser, but for a distal tract ablation, I don't believe in making the patient 10,000 more. But this is my bias. So, what is your practice and what is your principle?
Actually, we need to think about the fistula patient. I don't want to see him again suffering. You do with laser, without laser, lip procedure, whatever procedure. some amount of pain, some amount of suffering, some amount of poor quality of life, recovery period, he is suffering from that. And trauma to the patient, any surgery is always there. So for that purpose, the on table, whenever possible, maximum remove the disease as much as possible rather than ablating, I personally believe. Because I don't want my patient to have partially ablated tract, again he is coming. Rather than that, remove completely medial central disease and also lateral disease
So
completely.
your preference is to do a fistectomy whenever possible. That's what you mean to say.
Yeah, I
The
remove the
distal
tract.
tract.
Pill take, I take complete tract till the external sphincter.
Okay. So you close the external sphincter on the anal side and also in the other side, is it?
Yeah, on other side I don't close, but I do go till the external sphincter, so that I am happy that I have what sir has shown in all cases. We remove the tract completely. Laser, I personally tell openly that for patient I will tell I will use laser for ablating as good as monopolar. But for me on table laser doesn't has any value because I want my patient to come with a good outcome.
All right. Sir is ready with the other
Yeah,
case, I think.
sir.
Hello. Can we have the surgical video, sir's audio, please? Can we have the audio from the OT side, please? Hello. Hello. OT audio, please. Sir is not audible. Hello. Sir, we are not getting your audio, sir.
Sir, audio illa sir.
Partha, sir, your audio is missing.
Also with intersphincteric opening.
Yes, sir. Yes.
Hello, hello. Yes, yes. So this case also, Balu, there is no external opening,
Okay,
and
sir.
it's also abscess, and patient have an internal opening. That also I am not able to feel it. It must be deep. I could see some hardness here, and complaints is severe pain during and after devication because of the no abscess in the deep seated abscess. So here also I'm entering is patient got intersphincteric abscess also. So what I think is if I enter the intersphincteric plane, I could able to reach the horso abscess, and then I cure it, and then I can keep it drain. And if possible, if I can able to, there I cannot able to ligate the tract, and I can do some closer if it is possible on this intersphincteric side. That will come out basically.
Okay, sir.
And then I'm making this to a regular fistula instead of this complex abscess. It become a regular fistula. Then next
Intersphincteric
stage we can
fistula.
able to
Yes, sir.
manage. This can be done in a supine also, and anyway I do it in the prone. And this is the mecotonic junction. I'm entering here to reach the intersphincteric plane. நீ கை எடுத்து அது பிடிச்சு இங்கே கை சிஸ்டர் இது மேலே வரக்கூடாது, அவங்களுக்கு கேமரா மறைக்க இப்படி தான் இருக்கும். Thin line of small fat plane will be there between the sphincter. If you are entered in the right plane, there will not be any stitching. First thing, okay, hold this. See, I'm giving like this, you are holding like this. Here also, if I not in a plane, then I will enter it to the mucosa. So deep seated, you can see still I'm not getting any fibrous area or any abscess cavity. Mucosa ரொம்ப தின்னா போகுதுடா. இதை சேர்த்து ரிட்ராக்ட் பண்ண கீழே அழுத்தக்கூடாது எப்பவுமே. யூ ஹேவ் டு ரிட்ராக்ட் அவுட் சைட். சரியா? யூ ஷுட் நாட் புஷ் டவுன். நியூ பேட்ச் ஆஃப் பேஜஸ்.
Yes.
So video కొంచెం தெரியல லைட் அட்ஜஸ்ட்.
ஓ மறைக்குதா? ஓகே ஓகே ஓகே, 1 minute. ஏ சைட் டில்ட் கொடுங்க.
The inferior retractor is coming,
ஓகே
sir.
ஓகே போதும். இப்படி வெயிடா, அதான் சொல்றாங்க. சரி, அது வேற இவ்வளவு இருக்குன்ற கை வச்சிருக்கு. Here also the stretch of this sphincter, no, the strapping is not adequate. There is no stretching of the muscle, so I feel it will be difficult to enter into the plane. கை பிடிச்ச விட்டுரு, கை எடு. ரொம்ப இன்னும் மியூக்கோசா ஓட்டு. I'm not feeling any, almost normal only. I'm not feeling any track or anything. Here some fibrosis is there. We'll see.
How many days back was the scan done, sir?
Scan done recently only. எப்போ பண்ணிச்சு பாரு. எம்ஆர்ஐ எப்போ பண்ணிச்சுன்னு பாரு.
Many times our patients come after a long time with antibiotics. We are sometimes stuck.
Yeah, it is 21st March.
That's right, sir. Almost 20 days now.
10 days and here 20 days back. Yeah.
20 days, yes, sir. So with antibiotics.
Yeah, it's almost. I could see some structure, fibrous structure is coming in the view. நீ கையெடு பார்க்கலாம். அழுத்து. If a fibrous tract is I could able to find ligate, then treatment is completed. I thought of only the drainage for this patient. இங்க retract போடு vision நல்லா இருக்கு. அது போட்டா எனக்கு மறைக்கணும். சரி ஓகே அப்படியே வச்சு. Can you see this area?
Yes, sir. It looks like a fibrous,
Yeah, some
maybe a
fibrous
tract.
area. I'm just encircling that area.
Sometimes if we find an abscess and it's clearly visible, I try to inject a little methyl blue into the cavity with a green needle so that it may show up in a dissecting with a bluish tinge. If at all the tract is not very clear, sir. Do you anytime use an injection of methyl
Yeah.
blue
If
into
it
an
is,
abscess cavity, sir?
yeah, I'll inject methylene blue, but not routinely. Uh, that will be helpful to see the entire cavity. Can you see I went on either side?
Yes, sir.
Here
Looks
is
fairly
there,
wide, sir.
a fairly wide tract, and anteroposterior depth is also it looks more. Maybe healed abscess, no hot abscess. So now only I could able to enter the anterior wall. Okay. எங்கே வச்சிருக்க இப்படி பண்ணணும் இங்கே பண்ணணும் அதை மட்டும் எடுத்துறாது அப்படியே இருக்கு இங்கே இங்கே போடுறா இங்கே பிடிச்சி இப்படி பண்ணு ஸோ தட் அங்கே மறைக்காது புரியுதா they're also deeper so maybe if they're not getting good vision tell me I will retract and then okay I cannot confirm whether it is sac or not because there is no external opening anyway I'm going inside ரெண்டு பேருமே ஒன்று whether this case also the mucosa is getting injured I don't know can you see this thicker fibrous area
Yeah, it's fairly very wide.
yeah இதை பிடிச்சிது சிஸ்டர் so I'm just trying to making it out thin out
We have not seen any granulation, no, sir. We have not seen any
no
granulation.
not seen any
Yes.
granulation I not went deep but anyway I'm going to ligate and then if it is even a small granulation or hole is there then it's good there is no hole then I don't know what to do because I'm expecting a abscess cavity here okay anyway I ligate and then divide even if a hole is any track or anything is there it will be ligated once you divide then ligation will be difficult we have to take a transfixation or a posting kind of suture இது ஸ்ட்ரக் பண்ண சிஸ்டர் Still I'm not seeing any hole. Still not seeing. Not seeing. Yeah, now can you see
Yeah,
now?
some granulation.
Yeah,
Yes, sir.
yeah,
Yes, sir. We are able to nicely see a
yeah,
granulation. No pus, but definite granulation.
yeah, granulation maybe healed. இது வர மாட்டேங்குது sister. நான் வேற ஏதாவது அமுக்கணும். நீ டக்குன்னு எடு sister. Yeah. Now you can see more. So much is coming from the distal end. புடிச்சுக்க. Whether I ligated completely or partially, I don't know. It looks like partial ligation. Can you see no so much granulation? புடிச்சுக்க sister. இதோட புடிச்சுக்க. இல்ல இது திருட்டு புடி.
நான் பிடிச்சேன்.
இது கூட பைட் எடுத்துக்க. So now I have to close this one. இது கூட. I couldn't see the another wall. Can you see here?
Yes,
Yeah,
sir.
no,
Yeah,
granulation.
even I introduced the right angle. I take out the granulation. Saline food. So the antibiotic works well for this patient. It's become a tract now instead of abscess. இது என்ன செக்ஷன் பண்ற சும்மா நின்று இருக்கு.
இதை போது மாற்றணும்.
So I have to find out the post wall of the tract. That is anterior wall of the tract. Since the patient is prone, anterior wall of the tract. If I divide it, then I suture is better. Or it is a I ligate the tract, but this may be the cavity. It might be the intrasphincteric abscess was there. I think it is a cavity. So MRI wise there is a intrasphincteric abscess. Bipolar.
Yes, sir. So if you take a good figure of 8 or a box stitch on the
Yeah, figure
interval,
of 8
maybe.
stitch around this, and then if I close this is better. Yeah. So this see now I'm taking a deep.
Yes, sir.
The loop is helping me to pull out the track. Okay, tip பிடிச்சிக்க. இங்க retract பண்ணு. இது retract. இப்போ கையெடு. இப்போ இந்த எக்ஸ்போசர் தெரியுது இல்லை, இதே அளவு இருக்கணும். நீ retract பண்ணிட்டு போகணும். ஓகே. ரொம்ப இந்த பக்கம் வராத கொஞ்சம். கொஞ்சம் அப்படியே. The fibrous tract sometimes tightening is see it's cut. கூட சீசன் கட் ஆயிடுச்சு. 10. I'm taking a little thicker suture. கூட இதே கூட பரவாயில்ல. அது கட் பண்ணு. ஆட்ரு பிடிச்சிக்க. இழுக்கணும். கையை மடக்கக்கூடாது. வெளியே இழுக்கணும். குடு சீக்கிரம். This time I include the internal sphincter more. பிடிச்சிக்க சிஸ்டர், இதை பிடி, கொடு 4-6 கொடு. சரி, இதை பிடிச்சிக்க. இது அடியில் இந்த பக்கம் விட்டுரு. எஸ் எஸ். ஸோ ஐ மேட் அ ஃபிகர் ஆஃப் 8 சுவிட்சர். இந்த இது கொடுக்காது, ரெகுலர் இது கொடுக்கும். லூஸ் பண்ணிக்க, எடுத்து 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 இதே லூஸ் பண்ணிக்க. அதுக்குள்ளே எடுத்துட்டேன். சே,
இல்ல நான்
டைட் பண்ணுறது எதுக்கு எடுக்கிறேன்? கொடு. இப்படி கொடு, இங்கே கை வை, பிடிச்சிக்க. இது விட்றா, பிடிச்ச விட்றா. ஒரு நல்ல பழக்கம் இல்லை. ஆர்டி 4-6 கொடு, மஸ்கிட்டோ கொடுக்குறேன். I'm not seeing anything is going all around. Okay, just I'm coming out. I curated that area. There is no. Can you see here? Are you able to see this side, this place? There is only the cavity. There is no horseshoe extension. I could see. Saline kudu. தெரியுதா? கிளியரா இருக்கா? ரொம்ப அழுத்தாத, ரொம்ப அழுத்தாத. Okay, come out. Okay. See, quite deep. Quite deep.
Sir, in this patient, will you leave the intersphincter space open or partially open, sir? Because it was an abscess instead of fully closing it.
What, Balu?
Sir, because this was an intersphincteric abscess as a working diagnosis, instead of fully closing the intersphincteric space, will you leave the intersphincter space partially open?
I leave it a little bit open, not fully. This side one stitch, this side one stitch. And it's not a very active pus, active discharge is not there. So anyway, the source is ligated. Cavity also, I introduced the artery forceps, it's not going on either side.
Right.
So temporarily blocked. So I put one suture here, centrally it will be open. I can introduce a catheter to give was postoperatively.
Okay, sir. The MRI was a horseshoe abscess, but we have handled only intersphincteric.
MRI has abscess, horseshoe abscess with intersphincteric abscess. But I couldn't feel any abscess cavity because I went so deep. If this intersphincteric abscess connecting to horseshoe means it will be open up now. Or post-operatively it will open up and then pus will be drained through this in the lift wound. Where am I? இங்க ஒன்று போடு, இப்படி ஒன்று போடு, இப்படி ஒன்று போடு, சென்டரில் ஒன்று போடு, கேப் இருக்கு போடு. I told Snape to put the closer of the wound. So I told 12 to 3 o'clock, already 3:05. So meanwhile, any questions from the audience, we'll discuss Paulo, and then we'll. Because I have one more cases, but I think it's 3 hours is good enough. I think. Yeah.
Yes. Yes.
Thank you, Samrat, Balu, and Pinak. It's a last minute notice. I told you only yesterday, and all of you spent all the 3 hours and sharing your knowledge, answering all questions. and I also learned some of the points today from you, and I'm so happy.
Thank you, sir.
So maybe in the next conference, next meet, I'll inform you before.
Yes. Sir,
So
it is
you
an opportunity. Whenever you call, there is no.
no. See, everybody is now having a OP, ward patient, and the surgery
There
case.
is a.
So because of me, you omit all those three things, for these 3 hours. So I'm so grateful.
We
Thank
learned.
you. Yeah, thank you so much.
Thank you.
And we'll meet soon. Huh? Thank you. Thank you.
Yeah.
Bye.
Thank you,
Bye.
sir. Thank you.
Thank
Thank
you.
you.
1 minute. There is a question. It seems. A proctoscope. The proctoscope, Guru sister. So this proctoscope, it is just a cut endoscope and metal one. It is not a plastic one. And initially, I used from the beginning. I'm using this. I got it from Arun Rajanaskal. And now many Indian. Do you know any Indian company name? Samrat, Balu, Pinak, making this same type of
They
proctoscope.
make, sir, but it is not as good as what we are having this anoscope, sir.
Okay. So this is a proctoscope, but companies are making, because I gave this proctoscope to almost 4 5 Indian companies. They find difficult to make it. I don't know what is the difficulties. They told it's very difficult to make, but this is one of the very good proctoscope. What I feel, I have another one with the hole will be there. Suppose you are doing with the lithotomy, you can introduce proctoscope and then it will come out, patient stain. So you can fix it, hole will be there here, 2 holes.
Yes, sir.
You can fix it with the skin, perianal skin, so that it will not come out. So, but I'm not using that one regularly because the weight, this is more than that. So we need a base weight more so that it will be stretched the anal mucosa, so you can identify the internal opening very well. So we have to find out this cut anoscope, metal anoscope with a base, solid base with a cut. So any company is making this, then that will be good for doing lift. Okay. Yeah, surgery instruments, yeah, I'm using a regular instrument. I'm not using anything special. The question is which instrument you are using for surgery. So this is another anoscope with a central hole. You can see the hole is there, so that I can able to suture. Compare with this, size is also little thinner, and weight is also less. So I like this old one. It is still, no, I'm using this almost 2012 I bought. 12 means 12 years, 12 years old, this one. And the instrument, I'm using a regular instrument, except that retractor. This retractor, this is the retractor from Rajanaskal. Even the sign, Rajanaskal sign will be there, and it is a like regular copper retractor. In those days, we used a copper retractor. The same way, only thing this you can bend it slightly, so you can hold like this, and then you can retract. Since the lift wound is very small, what 2 centimeter, I'm using this. If this is a bigger size, if I use this one both side, then there will not be any space, no. And suppose you are going deeper, then you can use this deeper, no, wider blade. You can retract, but most of the time, this two is enough. And I feel very strong one. It looks thin, but it's very strong. And any copper retractor, you can make it and you can bend, and then you can use it.
So now Ekta Surgical is making, sir. You asked me which company, no, sir. Bombay-based Ekta Surgical is making similar to
Spell. You can spell that company name, Balu.
EKTA, sir. Ekta Surgical, sir.
EKP.
EKTA, Ekta Surgical, Bombay,
Yeah,
sir.
EKTA,
Yes, sir.
Ekta Surgical from Mumbai is making this blade,
It's
and
slightly
you
bigger, sir.
can
It
type
is
it in
not
the chest
even
box.
the scope they are making, but it is slightly bigger, sir. I have one from Arun
Okay,
Rajana Circle, sir, but I have one from this also, but this is slightly bigger.
okay,
The Indian company one is slightly bigger.
bigger,
And
okay.
Arun sir was telling that it is handmade by some local person there. So
Company, yeah.
this they are casting
So,
and doing, so it's not finished, is not coming good.
yeah, and some of them they ask this thing. I gave Arun Rajanaskal's mail ID. You can just mail him. He will send the proctoscope. So like that. Now anyway, the Indian companies are making. I think we can use that one. Yekta Surgical from Mumbai. Okay. Okay, Balu, Pinak, and
Thank you,
Samrat, thank
sir.
you so much.
Thank you,
Thank you.
sir.
Bye.
Thank you
Bye.
for the nice demonstration of difficult cases, sir. Thank you so much.
Thank you. Balu.
Thank you.
Thank you, Samrat. Thank you, Pinak.
Thank you, sir.